So good afternoon.
Yeah.
Good afternoon all. I welcome to all of you on behalf of NOGS and Mediscan. Happy to see that the list of our inquisitive delegates is still inflating and requests are coming from all over India. Of course, it's the magic of Dr. Suresh sir. Today we have sessions are devoted to first trimester screening, early pregnancy, 11 to 14 weeks pregnancy, then common anomalies and 6-step approach of Dr. Suresh, followed by virtual demo. Of course, we are getting some teething problem, so they will be solved over a course of time. I invite the first speaker. She is the president of Erode OBGY Society, Dr. E.S. Usha, and she is the coordinator of First Nodal Center for BDR. Her areas of interest are high-risk obstetrics and fetal medicine. She is an alumni of Coimbatore Medical College and she did her post-graduation from Kasturba Medical College. She did her fellowship in fetal medicine in 2008 from Mediscan. And she's conducting ultrasound training program in association with Mediscan Chennai. Right now, she's a senior consultant in Lotus Hospital, Erode since 2000. And she's conducting ultrasound training program in association with Mediscan Chennai. So welcome, ma'am. Welcome to this platform.
Good evening, everyone. Can I share my screen now? Please enable me to.
Yes, ma'am. Please share now.
Is it seen well?
Yes.
My screen. Okay. So my talk is going to be on early pregnancy scan. And it also will include some features of ectopic pregnancy also. So the learning objectives of this talk will be, at the end of this session, you will recognize the typical ultrasound appearances of the normal pregnancy between 4 and 10 weeks of gestation, to recognize the features of pregnancy failure, understand the role of measurements in early pregnancy, and recognize the typical ultrasound appearances of ectopic pregnancies. So the key questions that will be answered during this lecture will be, what are the normal appearances of gestational sac, yolk sac, and embryo? How should the gestational sac and embryo be measured? What criteria and terminology should be used to describe the non-viable intrauterine pregnancy? What are the typical ultrasound features of an ectopic pregnancy? And what is the role of ultrasound in managing pregnancy of unknown location? So what's the preferred route to do ultrasound in the early gestation? The preferred route is transvaginal ultrasound, because we all know the transvaginal route, the transvaginal probe gives higher resolution because of the higher frequency. And we will also be able to go closer to the organ of interest. So the resolution will be better. And in this early gestation, the fetus is very small and it is always preferable to have higher magnification and better resolution. So the route preferred is transvaginal. And we should understand the difference between the menstrual or gestational age and the conceptional or embryonic age. So the menstrual or gestational age is what we use clinically. This is calculated from the last menstrual period. And the conceptional or embryonic age is used mainly by the embryologists. So that is calculated from the day of fertilization. So we all know that it takes at least approximately 14 days for ovulation to happen in a regular cycle. So there'll be 2 weeks difference in this. So in ultrasound and in other ways clinically also, we use the menstrual age or the gestational age. So if we are referring to some embryologic book, so we need to understand that we'll be 2 weeks ahead of it. And we all know up to 10 weeks, this is called as embryo. And after that, after 10 weeks, we call it as a fetus. So what we are going to see today is all about the embryo. So after fertilization, we know the fertilization happens in the ampullary portion of the tube, and this fertilized ovum migrates towards the uterus. And in the uterus, after 1 week of fertilization, it gets implanted, usually in the upper part of the uterus, into the endometrium, usually on one side of the endometrium. But at this point, it is too small. It is still not visible by ultrasound. For us to see anything in ultrasound, it has to be at least 1 or 2 millimeters. So by the time the gestational age becomes 4 weeks, the gestational sac becomes visible, because at this time it reaches about 2 to 3 mm. So the visualizing a gestational sac, otherwise it's a chorionic cavity, is the first sign of pregnancy on ultrasound. So a completely embedded blastocyst, which happens after 14 days post-conception. So what are all the features of a gestational sac? So it is a small round fluid collection seen within the uterine cavity. It's normally positioned in the mid to upper uterine cavity. And you can see here, it is clearly seen surrounded by a hyperechogenic rim. This is the chorionic tissue. So the chorionic tissue appears hyperechogenic. So you have to make sure that the fluid collection is surrounded by a hyperechogenic rim. And usually it is located slightly paracentrically in the decidua. That means it's not exactly in the cavity of the uterus, because we all know when the fertilized ovum gets implanted, it buries, and the endometrium, by then which becomes the decidua, it covers the buried sac. So you will see it a little on one side of the endometrium, not exactly into the cavity. So this is called as the intradecidual sac sign. And we should remember that whenever we see a fluid collection inside in the uterus, we have to make sure that this is a gestational sac and not otherwise. For that, this feature is very important. Very early in gestation, you must make sure that it is paracentric or intradecidual. Because there are some other cystic findings which can confuse us with the gestational sac. This could be subendometrial cysts. So here the cyst will be below the endometrium or below the decidua. So if we look carefully, if it is not within the decidua, so we know it is a subendometrial cyst. The other confusing picture can be decidual cyst, but this is more confusing because this is seen within the decidua. A slight difference between the gestational sac and decidual cyst is the gestational sac will be abutting the midline echo line, but whereas this interstitial decidual cyst will be little away from the midline. And of course, whenever we have a doubt, we know the gestational sac keeps growing at least 1 millimeter per day. So if you call them back after 2 or 3 days, we will know that the gestational sac grows, but these subendometrial cysts or the decidual cysts will remain the same. The other feature which can confuse is the endometrial cavity fluid collection. So here we know it is within the cavity. It is not on one side of the endometrium, it is within the cavity. So because of that, it will conform to the shape of the cavity. So it may not be spherical, it may not be turgid. It will take the shape of the cavity. And if it has some blood, it will have some internal debris also. Because we are worried about this in the context of a positive pregnancy test, whether this could be a pointer for a ectopic pregnancy with some fluid in the cavity. So we have to give importance to the other all other features, like whether it is on one side of the endometrium, that is paracentric, and also you must look for the echogenic rim. So there's another feature which can help us to identify that this sac is really an intrauterine pregnancy, that is the double decidual sac sign. Because we know the decidua, after the embryo gets implanted, it's divided into 3 parts. One is the decidua basalis, and we have decidua capsularis and the decidua parietalis. So these 2 decidual layers with a little bit of fluid in the endometrial cavity can be seen as 2 separate lines. But we have to remember that if you see a double sac sign, it confirms that it is an intrauterine pregnancy, but it can be absent in up to 50 to 60% of even normal pregnancy. So the presence of a double sac sign helps us to identify that this is an intrauterine gestational sac, but the absence does not exclude it to be an intrauterine pregnancy. So the first structure what we see within the gestational sac will be the yolk sac. So once we see the yolk sac, this confirms it to be an intrauterine pregnancy. So we don't have to bother about the other features. So the minute you see yolk sac, this has a 100% positive predictive value that this fluid filled space is the intrauterine pregnancy. So this yolk sac is spherical in shape, It has an echogenic periphery and it has a sonolucent center. And it is attached to the embryo by vitelline duct. So sometime during pregnancy, we will be able to see this vitelline duct. The yolk sac is visible between 5 to 5.5 weeks of gestation, when the mean sac diameter is about 5 to 6 mm. And usually the yolk sac is seen 3 to 5 days prior to the embryo. And the yolk sac slightly increases in size, and the maximum size of 6 millimeter is reached at 10 weeks, and then slowly it decreases. So the yolk sac helps us to identify the amnionicity in multiple pregnancies, because the number of yolk sacs corresponds to the number of amnions. So here in this picture, we can see there are two sacs, and you can see a little bit of chorionic tissue between these two membranes. So this is called the lambda sign. So when you see a lambda sign and two sacs like this, we all know it is a dichorionic pregnancy. But in these two pictures, we see there's only one sac. So this is a monochorionic pregnancy. So now we need to understand how many amniotic membrane are there. So if you see here, you can see at least two fetuses, but you are not unable to see any separating membrane. But we are able to see 3 yolk sacs. So this tells us at least there are 3 amnion. So this is a monochorionic triamniotic pregnancy. Whereas in this picture, if you see, you can see 2 fetus. You are unable to see any membrane dividing it. You can see amnion only in this portion. And you're also able to see only 1 yolk sac. So this confirms that this is a monochorionic monoamniotic pregnancy, because 1 yolk sac corresponds to 1 amniotic membrane. So this is a monoamniotic pregnancy. So next to the yolk sac, we start seeing the fetal pole. So the fetal pole is seen around 6 weeks of gestation. It appears along the one side of the yolk sac. It is together, it looks like a diamond ring. So I already told, for us to see anything on ultrasound, it should at least be 1 to 2 mm. So at this gestation of 6 weeks, the fetal pole is about 1 to 2 mm. A little later, at around 7 weeks, we see the amniotic membrane. So you can see this is the amniotic membrane. So you can see the fetus on one side at this gestation, you see the amniotic membrane, and you will have the yolk sac on the other side. So this amniotic membrane, within it contains a clear fluid. So this is the fetus, and this is the amniotic cavity. And we know this is the chorionic cavity. And in between these two is called the extra embryonic coelom. So initially at around 7 weeks, the extra embryonic coelom is very big because the amniotic cavity is small. And this amniotic cavity gradually expands, and then at around 12 to 16 weeks, this amnion and the chorion fuses. And by the time it obliterates the extra embryonic coelom. So fetal cardiac activity, actually, that's the fetal heart is the first structure to start its function. So it is usually detected at 5.5 to 6 weeks, when the CRL is about 2 to 4 millimeter. Actually, the minute you see the fetal pole, usually we will be able to identify the cardiac activity. So the cardiac activity, that flickering movement, only will catch our eyes and to for us to see the fetal pole. But some cases, the fetal cardiac activity may be a little bit delayed. So it should be definitely seen when the CRL is of 7 millimeter. So the normal fetal heart rate is slow to begin with. So before 6 weeks, it's about 100 to 150. It increases and shoots up to 140 to 170 around 6 to 9 weeks. And then once the sympathetic parasympathetic system matures, after 10 to 11 weeks, it settles down to 140 beats per minute. So if you just see week by week what happens in the gestation, at around 6 weeks, the embryo is first visible as an echogenic area on one side of the yolk sac. So you know this is the yolk sac, this is the fetal pole. It is around 1 to 2 mm in length. It is just a linear or a laminar in appearance. So this yolk sac is on the ventral side of the fetus, and you see on the dorsal side, you have the amniotic amnion. So this amnion at this time is restricted to only the dorsal portion of the fetus. So once the fetus elongates and then it undergoes its cephalocaudal bend, then slowly And as the amnion expands, it starts covering all the surfaces of the fetus. So at this stage, it is called the double bleb sign. So at 7 weeks, you can see the developing spine. It is seen as 2 lines, and we will be starting to see the limbets. And we know the fetal bowel and the liver grows at a much faster rate than the abdominal cavity. So this pushes the bowel into the base of the umbilical cord, so which causes a physiological bowel herniation. So this physiological bowel herniation is seen from 7 weeks onwards using a transvaginal ultrasound. So once the abdominal cavity also expands, this bowel returns to the abdominal cavity. And of course, we know it undergoes the rotation before it returns. So if you can see, this is the cross section of the abdomen. This is the cord insertion, and we can see the bowel here. So this is a video clip showing this the base of the cord, and we can see this echogenic tissue. You can see that this is the herniation of the bowel. And after 11 to 12 weeks, we should not be seeing this physiological herniation. So if you see any herniation after 12 weeks, then we call it as then we decide that it is pathological. So we have to identify between gastrophases and omphalocele. So we should not mistake this for an anterior abdominal wall defect before 11 weeks. It is the physiological umbilical hernia. So at 8 weeks of gestation, all this time we were not able to identify which is the head or the caudal end of the fetus. Now we are able to differentiate the head and torso. And here we will be able to see the cystic structure in the fetal head. So this represents the rhomencephalon, which will later develop into the 4th ventricle. Okay, so this, we should not mistake it for a cyst in the brain. So it is only the developing brain vesicle. And by this time, we will be able to detect the embryonic movement also. So at 9 weeks, we will be able to see the developing spine better, and the division between the ventricles happen, and we will be able to start to see the choroid plexus also. In the sagittal plane, we will also be able to see the ventricle in the forebrain and also the hindbrain. So when it comes to 10 weeks, the fetus resembles more distinctly as a human being. So now we know that this is a very crucial period, because at the first we just saw a small cavity, fluid-filled cavity around 5 weeks. And then by the end of 10 weeks, we are able to identify the fetus as a human being. So this much of development happens within this 5 weeks. So that is why this period is very crucial. So how do we date pregnancy in the first trimester? So we can use the mean sac diameter or the crown rump length. So the mean sac diameter is usually calculated by taking 3 orthogonal measurements of the gestational sac. So you get the longest view of the sac. So you get the length and the anteroposterior diameter, and then we rotate the probe 90 degrees so that you get the transverse diameter also. So once we get all these 3 measurements, you add up all 3 and divide it by 3. So the arithmetic mean of these 3 diameters gives us the mean sac diameter. And we know that mean sac diameter increases approximately about 1 millimeter per day. And with this mean sac diameter, using the graph, we will be able to identify the gestation age of the pregnancy. But doing a mean sac diameter, it has its own fallacies, because the gestational sac is not spherical all the time. As gestation advances, it can become more oval, or if it also depends on any space occupying lesion in the pelvis, or a full bladder also, or a myometrial contraction also can alter the shape of the gestational sac. So we may not be able to take a adequate mean sac diameter. So usually dating of pregnancy is not done by mean sac diameter. We use this to plan the next visit of the patient. See, if you have a sac and you don't see a fetal fold, so you need to know when to call them. So we know this increases approximately 1 millimeter per day. So we can plan when to call the patient next. So for that, we use the mean sac diameter. So the next is using the crown rump length. So crown rump length is the longest distance in a straight line from the cranial to the caudal end of the body. So you can see here, when the fetus is very small, you don't know which is the cranial or the caudal line. So you just make a straight measurement from here to here. And when the fetus is little bit bigger, then you have to use the criteria to measure the CRL. And plotting on this chart, we will be able to identify the gestational age. And the CRL also increases rapidly, approximately 1 millimeter per day in length. So according to the ISUOG guideline, how to measure the crown rump length. So we should get the midline sagittal section of the whole fetus. And ideally, the fetus should be oriented horizontally. And you should magnify it so that it fills most of the screen. And the fetus should be in the neutral position. That means it should not be too much extended or too flexed. And you should be able to see the endpoints very clearly. But when we measure the fetus between 6 to 9 weeks, the fetus is hyperflexed, as we can see here. So actually, we are not measuring the crown rump length. We actually measure because we take the longest distance. So actually, we will be measuring the length from the neck to the rump. So this is called neck rump length. When it crosses 9 weeks, actually, we will be measuring the crown rump length. Okay, now after seeing what is the normal appearances in between in less than 10 weeks, now we will move on to identifying the miscarriages. So a miscarriage is defined as a spontaneous loss of pregnancy before it would be able to survive independently. So it is either before 23rd week or the fetal weight of less than 500 grams. So misdiagnosis of a miscarriage is unacceptable as it may lead to inadvertent termination of a viable pregnancy. So that is why they have given a very strict cutoffs, because we all know at least when the fetus is 2 to 4 millimeters itself, we will be able to see the heart rate. But some more allowance is given so that we call it as, we take 7 millimeters as a cutoff. So this also allows for inter and intra-observer variability. And strict time intervals also are suggested to repeat scans when the initial scan is inconclusive. So what are all the criteria to call it as a miscarriage? So what is fine? There are some findings which are diagnostic of a pregnancy failure, irrespective of the gestational age. We don't have to bother about the gestational age. So if you have a crown rump fetus whose crown rump length is more than 7 mm, but you don't see a cardiac activity. So you can see here, by switching on the color, there is no color picked up by the fetal heart. So if you see such a big fetus without a cardiac activity, then we can straight away diagnose a pregnancy failure. Or in case you have a mean sac diameter of more than 25 millimeter and you don't see a embryo, here again, you can call it straight away as a pregnancy failure. Or if you have seen this patient before and you have seen a gestational sac with a yolk sac, so then we call them after 11 days. So by 11 days, you should be able to see a fetal pole with a cardiac activity. In case if you have seen the during the first scan, we have seen a gestational sac, but we have not seen a yolk sac, then we should call this patient after 14 days to confirm whether the fetal pole with a cardiac activity is present. So if you don't see all this, then these are features which are diagnostic of pregnancy failure. So any other feature is suspicious of pregnancy failure and we cannot conclude that it is pregnancy failure. So what are all they? So you know, more than 7 mm without cardiac activity, it is a definitive feature. So if the CRL is less than 7 mm, but still you don't see a cardiac activity, or you see a mean sac diameter of 16 to 24 millimeter without an embryo, or you have seen a gestation sac with a yolk sac and you are seeing her again between 7 to 10 days and you still don't see an embryo with an cardiac activity, or if you have seen a gestation sac without a yolk sac and you are seeing them after 7 to 13 days and you still don't see embryo with cardiac activity, or if the person is very sure of the last menstrual period and you don't see an embryo after 6 weeks. So all these raise the suspicion. Still, you cannot conclusively tell that this is pregnancy failure. You will have to wait for a few more days before we call it as a pregnancy failure. There are some other features also which are suggestive of pregnancy failure. If you see an empty amnion with no visible embryo, because we know you see the yolk sac, you see the fetal pole, and then the amnion appears. So you see an amnion, but still you are not seeing a fetal pole. That means the fetal pole has not appeared. So that is again a suspicious finding. We know that the yolk sac, the maximum normal diameter is about 6 mm. So if it is more, see here, you can see this is to be a 8.3 mm. So straight away, you can't call it as a pregnancy failure. These pregnancies need to be followed up. This raises suspicion. And if you have a small gestational sac, so how do we call this as a small gestational sac? We take the crown rump length and we also calculate the main sac diameter. So if the difference is less than 5 mm, then we call this to be a small gestational sac. And in case you have a low placed gestational sac, so here again, you should not mistake it with a cervical ectopic or a cesarean scar pregnancy. If it's an intrauterine pregnancy, which is low placed, or if you have some subchorionic hematoma like this, or if the gestation sac appears irregular. So all this again raises the suspicion of a pregnancy failure. So all these fetuses have to be followed up more closely. Next, we move on to pregnancy of unknown location. So when we have a positive pregnancy test and we are unable to demonstrate any gestation sac, either intrauterine or extrauterine, we classify them to be pregnancy of unknown location. So on following up, this can become an ectopic pregnancy, or it can become a failed intrauterine pregnancy, or it can become a normal intrauterine pregnancy. So we have two models to work on it. We have an M4 model where the HCG values of 0 hours and 48 hours are taken and they are stratified into 3 groups and followed accordingly. The more recent model is the M6 model. Here, beta HCG and the progesterone levels are taken. If the progesterone level is less than 2 millimoles, then you repeat only the urine pregnancy test after 2 weeks. You don't have to repeat the beta HCG in these patients. But if the progesterone is more than 2, we have to repeat a 48-hour beta HCG. And then we put it in the model, which is freely available in the web. So if it tells it's a high risk, this is high risk for ectopic pregnancy, then we have to follow this with 48 hours HCG and ultrasound till we see the gestation sac. If it is low risk, which suggestive of failed pregnancy of unknown location, then we just have to do a UPT after 2 weeks. And if the model tells that it is low risk for intrauterine pregnancy, then we have to follow it up with the ultrasound after 1 week. So these models are highly sensitive, but they are not foolproof. So we have to keep a watch on the patient's symptom and the general condition also. If the general condition or the symptoms warrants, we will have to intervene early. So now we move on to ectopic pregnancy. So ectopic pregnancy is any pregnancy which is outside the endometrial cavity. So the most common site for ectopic pregnancy is the tubal pregnancy. So tubal, it could be isthmus or the ampullary region or the fimbrial end, or we can have an interstitial pregnancy. We can have pregnancy in the cesarean scar, ovarian pregnancies, cervical pregnancies, abdominal pregnancies, and also it could be a heterotopic pregnancy. So when you say a positive pregnancy test, when we do an ultrasound and we are able to see an extrauterine sac with yolk sac and the fetal pole, if you could see either the yolk sac or the fetal pole, then it has a 100% positive predictive value. Then you know that this is a ectopic gestation. But we are lucky to have this kind of a feature only in 20% of the women. So you can see the uterus here, you can see the adnexal mass, and you can see the sac with the fetal pole. Here you can see a sac with twin fetal pole. So next, there are two other signs which tell that this could be probably ectopic. So if you see an empty extrauterine sac, this is called a bagel sign. It is a round anechoic fluid collection with a thick echogenic crimp. And if you switch on color, it will give a ring of fire appearance. This again is seen in 20% of women. It is a 95% positive predictive value for an ectopic pregnancy. The other sign is called the blob sign, or if you see an inhomogeneous mass. So this mass represents the hemorrhage with blood clot. So this is seen in about 60% of women, and it also has a 95% positive predictive value. And in case if you see echogenic free fluid, that represents the hemoperitoneum. So you can see it in the pouch of Douglas around the uterus. And if the hemoperitoneum is massive, we will be able to see it in the Morrison's pouch also. And this is usually seen in about 25% of ectopic pregnancy cases. So when you have a positive pregnancy test and an empty uterus and a hemoperitoneum, it has a 90% probability that it is a ectopic pregnancy. Because if you don't see a sac or any mass in the adnexia and you are able to see only the hemoperitoneum, we have to think of other causes of hemoperitoneum also. That is why it is a 90% probability that this is ectopic pregnancy. So we now have another pregnancy, which is the interstitial pregnancy. That is the pregnancy which is happening in the interstitial portion of the tube. So it is seen in the corner of the uterus. So it has an eccentric location in the sac, and it is seen in the myometrium. And you must be able to demonstrate a clear separation from the cavity and the sac. So you can see this is the lateral margin of the cavity, and you see the sac here. And a finding which can help us to identify that this is an interstitial pregnancy is the interstitial line. That is the line joining the gestational sac and the endometrium. So, and you also may be able to demonstrate the myometrium surrounding the sac is very thin. So the most common, the most frequent variety which we are seeing now is the scar ectopic because of the high incidence of cesarean sections. So this sac will be triangular because it is accommodated in the scar area, and it is separate from the endometrial cavity. So here you can see this is the endometrial cavity and the sac is seen away from the endometrial cavity. So this is the endometrium and you see the sac over here. So it extends into the anterior myometrial wall, and here again the anterior myometrium may be very thin. So the next variety is the cervical ectopic. Here we see the sac in the wall of the cervix. So you can see a uterus and a enlarged cervix giving us a hourglass shaped uterus. So this we have to differentiate it from an impending miscarriage. So any sac which is there in the uterine cavity, if it is undergoing, it is in the process of abortion, then you may be able to see it in the cervical canal. So, but we have to remember the cervical pregnancy will be round, turgid. You may see a live fetus, but whereas in an impending miscarriage, the fetus won't be live and it won't maintain the spherical shape. It will conform to the shape of the cervix. And if you switch on color, the cervical pregnancy will have vascularity, but an impending abortion sac will not have vascularity around it. And you may be able to elicit a sliding sign because if you just move on the cervix, the sac in the process of miscarriage will move when we move the cervix, but whereas a cervical pregnancy will not be sliding. Because this differentiation is very important because if we think it is impending miscarriage, our line of management will be to go and curate it. But whereas if it is a cervical pregnancy, we will end up with a massive hemorrhage if we attempt to evacuate it. The next least common variety is the ovarian pregnancy. So it is very difficult to differentiate because within the ovary, you have to see a sac. In case if you are able to see a yolk sac or an embryo within the echogenic ring, it is easier to identify that it is an ovarian pregnancy. Otherwise, a corpus luteum also can mimic, even the vascularity of the corpus luteum also will mimic that of an ectopic pregnancy. So we may get confused with an ovarian pregnancy and a corpus luteum. So heterotopic pregnancy is a situation where we get an intrauterine pregnancy as well as an extrauterine pregnancy. So here we can see one sac inside and one in the outside the endometrial cavity. So this heterotopic pregnancy is not, it's very rare in a natural conception, but as the incidence of artificial reproductive techniques are increasing, we are also seeing more and more of heterotopic pregnancies. So we always have to remember it is not sufficient to see the pregnancy in the uterus alone, and our scan does not stop after seeing only the details of the fetus. We have to go and scan both the adnexia also. So you have to see the ovaries, the uterus, and the region in between so that we are not missing out any heterotopic pregnancy. So the key points are The first evidence of an intrauterine pregnancy can be seen at around 4 weeks using a transvaginal ultrasound. So at this 4 weeks, the mean sac diameter is about 2 millimeters, and we see a fluid field structure with an echogenic rim at this gestation. So dating of pregnancy is done by CRL in the early pregnancy, and we all know the variability is very less in the early gestation. So when by using a CRL, we can the variability is only 5 days in this gestation. So this will be the accurate method to date the pregnancy. And the strict criteria should be used to diagnose miscarriage. And the most common ultrasound appearance of an ectopic pregnancy is that of a heterogeneous mass. So thank you.
Thank you, Dr. Usha ma'am, for an elaborate lecture on early pregnancy scan. I think so all the delegates have some queries in their mind. They can put their queries in the question answer box so that they can be answered later. So Alka madam, should we proceed to the next lecture? Okay. So now I invite Dr. Divya Singh to give a lecture on 11 to 14 week scan. So let me introduce Dr. Divya. She is at present consultant radiologist at Prime Imaging and Prenatal Diagnostics, Chandigarh. She is a obs-gynae consultant, ultrasound consultant expert at Intelios. She is a member of ISUOG's CME task force. She is a member of online education working group of ISUOG. And she has also received a special prize and award by the Government of India, Ministry of Health, for her exemplary work for providing service to pregnant women in Chandigarh. And she has many publications and papers to her credit. So I invite Dr. Divya Singh to give her lecture.
Thank you, ma'am, for the kind introduction, and good afternoon, everyone. After that illustrative talk on the sonographic evaluation of the embryo, I will now start my presentation on the sonological appearance of the fetus at 11 to 14 weeks of gestation. And at the end of my presentation, you'll be able to recognize the normal appearance of the fetus between 11 to 14 weeks and know what are the components of a comprehensive sonological examination at this point of time. Now, if you're getting started with performing an 11 to 14 week scan, it's good to go through this paper, which is the ISUOG practice guidelines for performance of the first trimester fetal ultrasound scan. But if you note this, these guidelines are almost a decade old and actually due for revision. So it's a good place to start, but there is a lot more which has happened in the last 1 decade. Now, Professor Kypros Nikolaidis brought about this concept of inverting the pyramid of prenatal care more than a decade ago. Before that, most of the ultrasound scans were done in the 3rd trimester, as you see in this image, with very few scans done initially. Almost a decade ago, he proposed the idea of inverting this pyramid so that all women underwent a comprehensive assessment at 12 weeks, that is in the 1st trimester, and then they would be triaged into one group, which would have the majority of women, that is the low risk group. And then these women would just require a few scans, say 2 to 3 during the rest of the pregnancy, and would be managed like that. However, at this point of time, when we do this comprehensive assessment of women, we would identify a small group of low risk women, and these were the women who would require specialist care. They would be scanned more intensively and would require more testing. So this was a concept which was introduced more than 10 years ago, and now the 11 to 14 week scan has got multiple components based on this idea of his. First thing that we do at 11 to 14 weeks is measure the fetus, and that is done by determining the crown rump length. Besides measuring the crown rump length, we can also measure other fetal biometry, namely the biparietal diameter, head circumference, abdominal circumference, and femur length, just as we do in the 2nd trimester. The next important thing that is done at 11 to 14 weeks, which I'm sure all of us are aware of, is to screen for chromosomal anomaly. And the most important sonological marker for fetal aneuploidy at this time is the nuchal translucency. Besides nuchal translucency, there are other markers which I'll discuss shortly. Now, another important concept which we need to know is that the 11 to 14 week scan now includes a detailed assessment of the fetal anatomy. Just like we look for the anatomy in the mid-trimester scan, we can pick up various lethal and abnormalities of great significance at this point of time, which helps the couple to make an early decision regarding the management of pregnancy and to guide further testing. Not to mention the concept of screening for early onset preeclampsia. 11 to 14 week scan is a good time to measure the uterine artery Doppler and the uterine artery pulsatility index along with maternal characteristics, maternal mean arterial pressure, and certain biomarkers is then used to calculate the risk for early onset preeclampsia. And we all know we have the weapon of low dose aspirin in our armamentarium to prevent this if aspirin is started before 16 weeks. So this is a good time to screen for that as well. And also if you see multiple gestation, 11 to 14 weeks is the time to determine chorionicity and amnionicity, because as the gestation advances, after this time, it becomes at times very difficult to determine the chorionicity. And chorionicity and amnionicity are imperative to determine the future surveillance of multiple gestation. Now, besides focusing on the fetus, we also need to look around the fetus, as Dr. Usha eloquently brought it up, and we need to look at the placenta, the cervix, and the adnexae. Coming to gestational age assessment, as I said earlier, we can measure crown rump length between 11 to 14 weeks, and CRL is good for dating the pregnancy up to 84 millimeters. After 84 millimeters, the fetus tends to be more hyperextended. Even if you see a fetus around 80 millimeters, the fetal neck tends to be more hyperextended at this time, and hence CRL loses its accuracy in determining the gestational age. And after that, one should rely on head circumference to date the pregnancy. In case of natural conception, if there is a difference of 7 or more days between the expected date of delivery obtained by the last menstrual period and the expected date of delivery that you obtain by your CRL, then you have to consider reassigning the dates by the crown rump length. The ISWOG guidelines for measuring the crown rump length recommend that we obtain a mid-sagittal section of the whole fetus for measuring the CRL, with the fetus in a horizontal orientation, as you see here. The magnification should be such that the fetus fills most of the screen. It should be in a neutral position, which is determined by looking for this black amniotic fluid between the fetal chin and the upper chest. So if you see sufficient amount of fluid here, it means that the fetal neck is not hyperflexed, because if it was flexed, this fluid would not be seen and the chin would be touching the chest. If you measure the CRL in a flexed fetus, you would end up underestimating. You would get a smaller CRL. Also, if the fetal neck is hyperextended, that is, if the neck was stretched like this, then of course there would be increase in fluid under the chin. And at the same time, if you would measure this crown rump length, you would end up overestimating. Also, since you need to place the calipers, the crown and the rump points should be clearly identified in the image. Coming to measurement of the biparietal diameter or head circumference. Just as we use the transthalamic plane in the second trimester to take these measurements, in the first trimester, we can also obtain the transthalamic axial section, as you see here. It looks slightly different from that of a second trimester fetus, but here you can still identify these hypoechoic thalami on either side of the midline, separated by this echogenic third ventricle. So this is the transthalamic plane. And to measure the biparietal diameter, all that you need to do is place one point of the caliper on the outer border of the skull table in the near field, and the other point can be placed either on the inner border of the skull table in the far field or on the outer border, depending on which charts you use. If you use outer to inner charts, then measure it that way. If you use outer to outer charts, then that would be your method of caliper placement. Here I've placed outer to inner. And to determine the head circumference, you need to just obtain the occipitofrontal diameter, and the machine would calculate the head circumference for you. Head circumference can also be calculated by the ellipse method. Just a recapitulation of how to date pregnancy at 11 to 14 weeks. Now, if the pregnancy has resulted from assisted reproductive technology or ART, then one can use the embryo transfer or the blastocyst transfer date to arrive at the gestational age and determine the expected date of delivery based on that. However, if it's a spontaneously conceived pregnancy and the lady's last menstrual period is not reliable, then we would date the pregnancy by ultrasound, that is by the crown rump length that we obtain at this time. If the lady has a reliable last menstrual period, her cycles are of 28 to 31 duration, 31 days duration, that is neither too short nor too long, then we can rely on her dates and obtain the gestational age by her last menstrual period and the expected date of delivery. But please ensure that the difference between the EDD obtained by the last menstrual period and that obtained by the crown rump length is not equal to or more than 7 days. Because if there's a difference of more than 7 days, then you need to reassign the expected date of delivery by the crown rump length. Just an example to reinforce what I just said. Now, suppose we perform a scan in a lady with her weeks of amenorrhea at the time of scanning are 12 weeks, 3 days. So the EDD by LMP is 15th of June. But when I measure the CRL, the crown rump length corresponds to a gestational age of 11 weeks. So you see here, there's a difference of 10 days. So what happens? We'll mention in our report that the fetal dimensions show a discrepancy of 10 days with respect to the period of amenorrhea. And therefore, we would reassign the dates by the crown rump length. And so we would give her an estimated date of delivery based on the ultrasound, which would come out to be 25th June, 2022. So one should always document the expected date of delivery, whether calculated by LMP or by the CRL, clearly in the report. And once you've done this at the time of the 11-14 week scan, if you've done a proper scan or you see a reliable scan, do not change the EDD on her subsequent visits. Next important thing that we do at 11 to 14 weeks is to screen for fetal aneuploidy. And we all know that for that, what we need to do is measure the nuchal translucency. There are other markers for fetal aneuploidy, namely the nasal bone, looking for tricuspid regurgitation. This is normal flow across the tricuspid valve. You see normal forward flow. There is no evidence of reverse flow during systole, so no tricuspid regurgitation here. And this is the normal triphasic flow seen in the ductus venosus. Coming to the most important marker, that is nuchal translucency. Now, CRL estimation is important because remember, nuchal translucency is ideally measured between a CRL of 45 to 84 millimeters because we have got validated normograms for this CRL only. What we need to obtain is the mid-sagittal section again. And how do we determine that we are in the correct plane? We do this by looking at our image. In a good mid-sagittal view, you should see the following landmarks. Anteriorly, you would see the echogenic tip of the nose, as seen here. You would see the rectangular palate, as you see in this image. In the center, you would appreciate this hypoechoic thalamus or the diencephalon. And of course, you would see the nuchal membrane, which you are to measure posteriorly. Again, magnification is the key because this is a very small structure. So as to place the calipers correctly, you would use zoom. And which zoom is better? Right zoom. So you would use right zoom and place the zoom box in such a manner that the fetal head and thorax occupy that zoom box. And so when you magnify, they would be occupying your whole screen. Fetus again should be in a neutral position with sufficient fluid separating the chin from the chest, because if the fetus is flexed, you will underestimate. The nuchal translucency will be thinned out. So you would underestimate the nuchal translucency. And if the neck is hyperextended, you would overmeasure the nuchal translucency. Care must also be taken to distinguish the fetal skin from the amnion. Remember, you have to measure the widest part of the translucency, and the crossbars are placed in such a manner, that is, they are placed inner to inner in such a manner that the calipers merge with these white lines. I'll show it to you shortly. Sometimes when you magnify the image, I think somebody brought it up last time as well, it's important to turn the gain down a bit so that the margins don't appear very fuzzy. If they appear very fuzzy to you, you can turn down the gain a bit, and then you can see these white margins better. Also, it's a good practice to take more than one measurement during scanning, and the maximum measurement of the NT, which meets all the above criteria, should be recorded as the final measurement. Now, just to show you a clip with the fetus in the ideal mid-sagittal position with optimal magnification, neutral position, you can clearly see the landmarks, the echogenic tip of the nose, the diencephalon, the palate, and the nuchal membrane. And this is a still image obtained from the same clip showing you the placement of the calipers such that the crossbars lie on the inner border of the white line and not in the nuchal fluid. Before you actually start measuring NT, it's a good idea to get certified so that you know what you're supposed to do and that you are a safe scanner. And this is a QR code of the Fetal Medicine Foundation UK site, where you can go do the theoretical course on NT, submit a logbook of images, and become a certified NT operator before you start scanning. These are just to show you some poorly taken NT images. You can see much of the landmarks here. You can appreciate some kind of an NT, though it appears fuzzy, but this is firstly a flexed image and a parasagittal image. It's just to show you what a parasagittal image looks like. Here, the palate no longer appears rectangular, but you can appreciate this white line, which is the frontal process of maxilla, which would be seen if you go slightly parasag. And this is again a hyperflexed NT. You don't see any amniotic fluid between the chin and the chest. This would result in underestimation of nuchal translucency measurement. This image is not acceptable. Coming to the next marker, that is the nasal bone. This is also seen in the mid-sagittal section. When you're looking for the nasal bone, please ensure that the echogenicity of the nasal bone is greater than the overlying skin, because a good ossified nasal bone has an echogenicity greater than the overlying skin. And the correct view of nasal bone should show you 3 distinct lines. So the landmarks, when you know you are in the correct plane for the nasal bone, would be 3 lines. First is this thin white line, which is the overlying skin. Then you see this thicker white line underneath it, giving an equal to appearance. This would be the normally ossified nasal bone. And finally, this is the third line, which is somewhat in continuity with the previous skin line, and this is the echogenic tip of the nose. So once you see these 3 lines, you know you are in the correct plane, and then you make an assessment of the nasal bone. Next, I move to the anatomy assessment. I told you this is a very good time to look for fetal anatomy, and you can detect some major lethal anomalies at this time. This is again a checklist provided by the ISUOG guidelines. And you can see there are some parts which are marked with asterisk. These have been said to be things that are optional, that you may or may not include them as a part of fetal anatomy assessment. But as I said earlier, we are in the year 2022 and these guidelines are a bit old. So if you have to be at par with your peers, you need to do much more in this year. A paper was published right after these guidelines in the year 2013, which sought to evaluate how many anomalies or to what extent the anomalies could be detected between 11 to 14 weeks. This was a landmark paper by Professor Kypros Nikolaidis, and they found that a high percentage, nearly 100% of abnormalities like acrania, ectopia cordis, encephalocele could be detected by performing a good 11 to 14 week scan. This was way back in the year 2013. Then the anomalies which could be detected with a detection rate of more than 50% included cystic hygroma, certain cardiac anomalies, abdominal wall defects, megacystis, and certain limb abnormalities. Open spina bifida, which you see here, at that time fell in this group of less than 50% detection rate. But come year 2019, this paper has been revised, and open spina bifida now falls in more than 50% detection rate group. And this is because certain new signs have come up for detection of this condition. Also, alobar holoprosencephaly, body stalk anomaly, and abdominal wall defects also figure in this nearly 100% detectable group now. So it's important to keep pace with the changing times. There are certain anomalies which are hard to detect or nearly undetectable at this time. This is because some of the structures in the normal course of development are not there at 11 to 14 weeks. For instance, the corpus callosum. And so there are certain conditions which cannot be detected, and that limitation shall remain. Also, there are certain conditions which evolve as the fetus grows. For instance, valvular stenosis, bowel obstruction, and they do not become evident at this point of time, something which we should be aware of. This paper also brought out the fact that as gestational age advances from 11 to 14 weeks, we become better at detecting anomalies. So rather than performing a detailed evaluation of anatomy at 11 weeks, it's a better idea to bring the lady at more than 12 weeks with a fetal CRL around 60 millimeters for optimal detection of anomalies, as well as for assessment of risk for fetal aneuploidy. Coming to various components of the anatomical scan, this is, let's start from the top. So we'll start from the head. This is what the transventricular plane in the fetus looks like. It's slightly different from what you see in the mid-trimester fetus. And if you move from outside to in, first we should be able to see the ossification of the calvarial bones, which is evident by 11 weeks. As beginners, please don't mistake these gaps which you see, areas which don't seem to be ossified, as some calvarial defects or some abnormality or lack of ossification, because this does happen sometimes. These are just normal sutures which are more wide at this period of gestation. So this is normal calvarial ossification. You see the frontal bones, the parietal bones. As we move in, we see the echogenic choroid plexus filling the lateral ventricles, forming a kind of butterfly configuration. And this echogenic midline structure separating the two choroid plexuses is the midline fox. So this is what a normal transventricular plane looks like. If we just slide our probe caudally, we would come to the transthalamic plane in the first trimester. You can see the thalami separated by this echogenic third ventricle. And another interesting structure, which is particularly large in the first trimester, is this anechoic rectangular structure known as the aqueduct of Sylvius. Now, why I'm focusing on these structures is because they do have relevance. Because of these structures, we have increased the detection rate of open spina bifida in the first trimester. So again, the transthalamic plane, you see this aqueduct of Sylvius. Please familiarize yourself with this structure and with the fact that the normal aqueduct of Sylvius does not abut the occipital bone. There is some distance between the occipital bone and the aqueduct of Sylvius. The midbrain has this arrowhead kind of configuration. And again, the posterior margin of the midbrain is separated from the aqueduct of Sylvius. Also, our friend, the mid-sagittal section of the fetus, which we use to see the CRL, the NT, and the nasal bone, is also used to assess another normal structure, which is intracranial translucency. Now, the fetal posterior brain in the first trimester has got 3 black spaces, as you see here, which are separated by 2 white lines. The anterior black space is the brainstem. The mid black space, which is called the intracranial translucency, is the 4th ventricle. And this posterior black space is the cisterna magna. Normally, we see these 3 spaces almost of similar size, and they are separated by this posterior border of the brainstem. And this echogenic line is the choroid plexus of the 4th ventricle. So this is again the normal appearance of the fetal posterior fossa in the first trimester, which you should get familiarized, because in cases of open spina bifida, this normal anatomy is distorted. I would not go into that because that is a topic of further discussion. It's also a good idea to be aware of this maxillo-occipital line, which is a line drawn from the superior border of the maxilla straight to the occipital bone. And normally, the junction of the thalamus with the midbrain, this waist-like thing that you see, normally is situated above this maxillo-occipital line. So these are all normal landmarks that you can be aware of. This is something extra to what you should know in the year 2022. Coming to the appearance of neck, this is what a normal neck looks like in the first trimester, that is at 11 to 14 weeks. You check the nuchal translucency, look for any abnormal cystic fluid collections, and remember that nuchal translucency is not only a marker for aneuploidy, but if you see a thick nuchal translucency, you should also look for non-chromosomal structural abnormalities, particularly the fetal heart, because cardiac abnormalities can also be associated with a thickened NT. Coming to the face, We know how to look at the fetal face in the profile view or the mid-sagittal section. We are aware of what the nasal bone looks like. This is the intact palate, which looks like an echogenic rectangle. This is the maxilla. And this dot that you see here is the mandible. So familiarize yourself with the normal profile. It's optional to see the orbits in the axial plane, and you can identify the orbits by the presence of the lens within them. Then another plane which is of importance, particularly in assessment of unossified nasal bone and cleft palate, is the oblique coronal plane, which is just obtained by rotating the transducer 90 degrees from the sagittal plane, because you just have to go from sag to coronal plane, and you can get this thing known as the retronasal triangle, the base of which is formed by the hard palate and the apex by the nasal bones. So this is the normal retronasal triangle. If there would be a defect in the palate, you would see a hypoechoic defect in the base of the triangle. And if the nasal bone was unossified, you would see a hypoechoic defect here. These two dots are the rami of the mandible, and this is the normal mandibular gap that you should see in this plane. Again, it's optional and actually really difficult to assess the lips at this time. For this, you would require, again, very high resolution images, transvaginal, which cannot be possible in every patient at 11 to 14 weeks. Coming to the spine should be assessed in two planes, longitudinal and axial. You can appreciate the vertebral bodies here and must look for the intactness of skin over the vertebral bodies, making sure that there is no overlying skin defect. You can use a high resolution probe. As you can see, I've used a linear probe here and in a thin patient, and I can appreciate the individual vertebral bodies and the overlying intact skin. Going more caudally, we come to the chest. In the chest, this is the axial section of the chest. Besides looking at the heart, first look around the heart, see for the symmetry of both lung fields, ensure that there is no abnormal fluid collection or masses. Coming to the assessment of the heart, as you see in this clip, we can see a 4-chamber view of the heart. You'll check for the cardiac activity. Heart rate can be measured when you assess for tricuspid regurgitation. One looks for the symmetry of 4 chambers. And again, though the ISWAG guidelines at that point of time spoke about assessing the heart only on B mode, if you would see the studies and presentations over the last 10 years, you would see that now even basic examination of the heart in the first trimester makes use of color Doppler. And what they recommend just for basic screening is first to obtain a section of the upper abdomen and the axial section of the 4-chamber view to determine the situs, to ensure that the stomach is on the left and the cardiac apex is also towards the left with a normal cardiac axis. And then one can assess for the symmetry of the cardiac inflows by switching on color Doppler, and we can see 2 symmetric inflows, same color. This is at the level of 4-chamber. And then at the level of 3-vessel trachea view, just as we do in the second trimester, one can look for the V sign formed by the ductal and the aortic arch joining each other to the left of the trachea. Going down further, we go and see the abdomen. In the normal abdomen, as we all know, stomach would be present in the left upper quadrant as seen in these images. The normal bladder is seen in the lower abdomen, and it can be identified if you're in doubt whether an anechoic structure in the lower abdomen is bladder or maybe a cyst. You can just switch on color Doppler and you can appreciate the umbilical arteries hugging the normal urinary bladder. The kidneys can be seen as these bean-shaped structures in the posterior coronal plane, and you can identify them by the presence of this anechoic urine-filled renal pelvis. Again, this is an optional section to obtain. As I said earlier, you can identify the urinary bladder by looking at the umbilical arteries. Some people do document whether the vessel, the umbilical cord is 2-vessel or 3-vessel, but personally, I do not recommend doing this because it often leads to a false positive call of single umbilical artery at this point when one of the arteries is very small and causes unnecessary anxiety. So this can be best left for the second trimester. Then coming to the abdominal wall also needs to be looked carefully. You can see the cord insertion site either in the sagittal or in the axial plane, and there should not be any intra-abdominal structure like a bowel or liver herniating through it. Remember, abdominal wall defects can be detected very reliably in the first trimester, so you should assess the cord insertion site. This is also a good time to look at the fetal extremities, because fetus tends to keep its limbs relatively extended and still at this point of time. And so it's easy to assess all the three segments of both the upper and the lower limbs easily. Even finger counting can be done quite easily because babies tend to keep their hands open majority of the time in the first trimester. Coming to the topic of twins, as I said earlier, 11 to 14 week scan is a good time to assess chorionicity, which determines the number of placentae in the pregnancy. And do not confuse the term chorionicity with zygosity. They are not synonymous. Zygosity refers to the number of zygotes, whereas chorionicity is the number of placentae. When we say that a pregnancy or twins are dizygotic, we mean that they have been obtained from two different zygotes. They are non-identical, and 70% of twins are dizygotic. Obviously, they've been obtained from different ova, fertilized ova, so they would have separate placentae, and dizygotic twins tend to be dichorionic, diamniotic always. However, monozygotic twins are a bit different. Though they come from a single zygote and are identical in their genetic makeup, they can be dichorionic, diamniotic, monochorionic, diamniotic, monochorionic, monoamniotic, and conjoined. Because in these cases, the chorionicity is determined by the day at which there is cleavage of the zygote. So if the zygote cleaves early, then there would be formation of fetuses with two separate placentae, that is dichorionic, diamniotic twins. And if the zygote cleaves late at the stage of formed embryonic disc, then we would have conjoined twins. So monozygotic twins can be dichorionic, can be monochorionic. This is just an image again at 11 to 14 weeks to show you how to identify dichorionic diamniotic twin pregnancy. You can appreciate this lambda or the twin peak sign, which occurs because of the growth of the chorionic tissue into the intertwin membrane. You can appreciate how the intertwin membrane in dichorionic diamniotic twins is thick. In contrast, in this monochorionic diamniotic pregnancy, you can see the intertwin membrane, but it is much thin as compared to the dichorionic diamniotic twins. And look at the insertion site of the membrane on the placenta. You don't see any chorionic tissue growing here. This is known as the T sign of monochorionic pregnancy. And finally, we come to monochorionic monoamniotic twins. So there would be a single placental mass. Since they are monoamniotic, you will not appreciate the amniotic membrane. Remember to look for the amniotic membrane in different planes, because amniotic membrane will only be seen, especially when it is thin, when your ultrasound beams are perpendicular to it. So you sometimes need to move around your probe and hunt really well before you can be sure that there is no amniotic membrane. And of course, in momo twins, you will also see cord entanglement often because they are in one amniotic cavity. Now moving outside the fetus, as Dr. Usha brought out, one may often see this thin amnion, because between 11 to 14 weeks, the amnion is not fused with the chorion. But while you're looking at this, you might have appreciated this biconvex or lenticular shaped heterogeneous lesion along the posterior wall of the uterus. And this is a subchorionic collection. You can see this is the amnion and this echogenic line is the chorion. So this collection is beneath the chorion. And this is what a subchorionic collection or a subchorionic hematoma looks like. So we can appreciate these sometimes when the women have got bleeding. We can look for these. And you can also see, if you look carefully in the myometrium, this lady also has fibroids. So just don't look on the fetus, look at the fetuses surrounding as well. And then the placenta. Of course, we do not report placenta previa at this time, but we note the location of the placenta. And if the placenta is low, and especially if the lady has had a previous C-section or some uterine instrumentation, we need to evaluate for ultrasound features of placenta accreta spectrum at 11 to 14 weeks, because there are studies which have shown that severe forms of placenta accreta spectrum can be reliably detected even at this time. First, let's familiarize ourselves with the normal placenta. Normal placenta at 11 to 14 weeks. This is an anteriorly situated placenta. It has a uniformly echogenic appearance. And look at this band. This is the normal hypoechoic retroplacental myometrium. So this is what you should appreciate in a normal placenta at 11 to 14 weeks. The placenta itself and the normal retroplacental myometrium, because this would be lost in cases of placenta accreta spectrum. And finally, the adnexa. As ma'am brought out, adnexa can have adnexal masses. You might even encounter ovarian tumors at this point of time. But the most common normal appearance that you see in the adnexa are these corpora lutea. This was a case of twin gestation, and I could see 2 corpora lutea within the same ovary. How do I know this is the corpus luteum? I see this characteristic hypoechoic rim. These corpus luteum tend to have a hypoechoic rim as compared to the ovarian stroma. So these are just normal harmless corpora lutea. And if I would switch on color Doppler, they would show this normal typical ring of fire around them. So with this, I come to the end of the presentation. I hope I've driven home the message that 11 to 14 weeks is a good time, and you can to measure the CRL and accurately assess the gestational age of the pregnancy. Besides looking for nuchal translucency, which is a marker for fetal aneuploidy and fetal structural abnormalities, one should look for other things like the fetal anatomy itself. In multiple gestation, 11 to 14 weeks is a good time to determine chorionicity and amnionicity, and it is something that you must do in every case of multiple gestation. And please do not forget to look beyond the fetus, because that might hold important information as well. Thank you.
Thank you, Dr. Divya, for your lecture. Madam, should we proceed to the next lecture?
No, I think we will do 2 things now. We will ask Mindray to make their presentation.
Okay.
Yeah, sir.
And then we'll take some questions before we go further.
Okay, sir. Okay.
Yeah. So thank you so much, Suresh sir, Dr. Alka ma'am, for giving us this wonderful opportunity, for being the academic partner for this excellent learning course, which is well curated by all the esteemed faculties. I would like to invite Ms. Shivangi Trivedi for giving small tech talk on Mindray's new technology for making clinicians' life much easy. Yeah, so over to you, Shivangi.
Thank you very much, Viraj. I'll just share my screen.
Yeah. You are able to share, right?
Meanwhile, Moshmi and Surekha, be ready with the questions.
Okay,
Don't
ma'am.
put the chat back.
Okay, ma'am.
Viraj, I'm not able to share my screen. Can you just give me access?
Yeah, you can share. I have made you co-host. Any problem?
Yes.
Okay. I have made you a host as well.
I do not get any options actually for sharing, screen sharing.
Is it?
Can we do one thing?
Yeah, sir.
Sudarshan is ready with the presentation. Let him finish it, because he's got
Okay.
some patients waiting.
Okay,
Then,
okay, sir.
yeah, after
Okay.
that, we can have it.
Yeah, sure, sir. Okay.
Okay. Sudarshan, are you ready?
Yes, he is there.
Yes. Okay. So I would like
Moshmi.
to, yeah.
Yeah.
So I would like to introduce Dr. Sudarshan, sir. He is a consultant at Mediscan System. He is a fellow and of fetal medicine at from Mediscan System, and he's a trainer and faculty, and he conducts workshops, lectures, and in various conferences. He is a co-investigator in the study of fetal size charts DBT funded project, and his clinical focuses are in first trimester USG screening, high risk multiple pregnancies, and invasive procedures. So I invite Suresh sir for your lecture of first trimester fetal anomalies.
Dr. Sudarshan.
Dr. Sudarshan. I'm sorry, Dr. Sudarshan.
Yeah, you can see my screen now.
Yeah, yeah.
Yes.
Okay. 6:50. At the outset, I would like to thank the Nagpur OB Society and Professor Suresh for making me part of this session. And you would have heard about the normal appearances of the fetal anatomy in the first trimester. And over the next 30 minutes, I would be taking you through the common abnormal appearances of the fetal structure in the first trimester scan and help you gain a care pathway to go forward. So at the end of this lecture, you will be able to identify common. There is some disturbance.
No urgent action.
Yeah. At the end of this lecture, you will be able to identify common malformations in the first trimester, provide a care pathway for these malformations, and understand what is identifiable and what is not. So when you look at the baby in the first trimester, you have a wide range of gestation between 11 and 14 weeks, which would be between a CRL of 45 mm to a CRL of 84 mm. And as you can see from this chart, the bigger the baby, higher is the detection rate of structural malformations. And that is not something very complicated to understand, because the larger the size of the baby, it would be easier for us to identify or differentiate between the normal and the abnormal appearances. At this point of time, I would also want to reiterate that in the first trimester assessment, a liberal use of the transvaginal scan would enable us to identify the abnormal appearances much better than in the transabdominal scan. And in any patient, if we have the slightest suspicion of a difference in the anatomy on transabdominal scan, or there is a challenge in the imaging of the fetus on transabdominal scan, we should use the transvaginal scan, and only then the imaging would be complete. If you look at this, by the time the pregnancy reaches 14 weeks, the detection rate of structural malformation is close to 75%, while at a CRL of 45 mm, it is an abysmal 45%. So an ideal time to look at the baby to assess the structural anatomy is somewhere between 12 to 13.5 weeks, because that is when you will be able to do an optimal screening for aneuploidy and also assess for structural malformations of the baby. So let's start assessment or looking at the common malformations, and we shall go through systematically from the head to the foot of the baby. The most common structural malformation that you would look at is an anencephaly, and it happens because of an absence of the cranial vault of the baby. And the calvarial development is visible after the 10th week, and hence should be careful never to make this diagnosis prior to a CRL of 40 mm or before 10 weeks. And at that point of time, if you have a concern, there is nothing wrong in calling the patient back a week or 10 days later. Mostly it's sporadic of inheritance. Sometimes it can be a part of an amniotic band rupture sequence. And if it is an isolated problem, the recurrence is less than 1%. If you look at this image, you have the abdominal wall of the baby. That's the head of the baby. You would have seen in the previous lecture that the calvarium is seen by an echogenic area right around the brain. And herein you have the brain matter of the baby freely exposed to the amniotic fluid, and there is no surrounding vault or calvarial bone around this. You can see the brain matter here, and there is no calvarial vault. And this is a diagnosis of an anencephaly. And by far, this is the most common malformation that you would pick up, and we should always identify this at this point of time in the pregnancy. So when we evaluate the calvarium of the baby, we also assess for the other problem called as a encephalocele. We saw that a complete absence of the calvarium is an anencephaly. When a portion of the calvarial vault is not developed and there is a brain tissue which is herniating through it, then we call it an encephalocele, or if there is only meninges coming out of it, we can call it a meningocele. If you can look at this, This is a calvarium that is fully ossified, but at the occipital region, there's a disruption in the calvarium, and there is a bulge seen behind the occipital bone, and that bulge also has got some septation area inside it, and hence this is a baby having an occipital cephalocele. And you can see this bulge right behind the neck of the baby. A large cephalocele is very easy to identify, and most commonly it is seen in the occipital region. Presence in the other regions are rare. However, if you have a baby having a very tiny cephalocele, if it's not as big, it's probably 1/5 of the size of this, and the baby is lying down flat across in the uterine wall in a supine status, then we may not be able to identify this, and hence we need to look for alternative signs. In most instances, it is a sporadic inheritance like any other open neural tube defect. The recurrence risk is low. 1% of the cases can have a chromosomal association. In some, there can be syndromes like a Meckel-Gruber syndrome or an amniotic band syndrome. And this is the calvarial wall, and there's a disruption here, and you can see the brain matter coming out. Similarly, seeing this baby that is in a standing plane. This is an example of a baby lying down flat. This is what I was explaining about. If there is a small defect here and the baby is lying down on the uterine wall, you may be able to easily miss this. And you will only pick it up in the second trimester when it's becoming deep. And that is why when you assess the crown to rump length, you assess the baby and also assess the back portion of the baby with a rim of lighter. And you also assess the calvarium or the vault of the baby always with lighter all around it, because then you will be able to ascertain the normalcy of the calvarium. This is how I am saying that there's a lot of lighter around it. You're able to see the calvarium all around, and in the occipital region, you can see the brain matter herniating around it. The occipital cephalocele can be commonly mistaken for a fluid collection behind the neck of the baby or a nuchal fluid collection, and it can be simply differentiated by the fact that it is seen communicating with the inside of the brain, and you can identify it on the simple transverse view of the skull of the baby. As I said, some babies can have other syndromes. So an identification of a cephalocele like this baby had a cephalocele should prompt a referral to a subspecialist who should be able to do a very detailed ultrasound assessment to rule out any syndromic causes. For instance, this baby has huge kidneys which are cystic and enlarged. That is just striking to the eye. And this combination of a baby having large kidneys and a cephalocele, this baby also had other symptomata, is characteristic of a condition called Meckel-Gruber syndrome, and that has got a genetic etiology. And hence, we should always look for other malformations once you identify a cephalocele. So this is the autopsy picture. This baby had a polydactyly, a large kidney, and a disruption in the calvarial wall, as you can see in this image. Once we have seen the exterior of the brain, you go to the interior of the brain. You must have heard in the previous talk that the calvarium inside the brain is divided into two halves by means of a fork that runs from one end to the other. When there is a failure of cleavage of the brain, especially the forebrain, in the transverse section that you see, then it is called a holoprosencephaly. Holo is single, prosencephalon is forebrain. Holoprosencephaly is a fused forebrain or a non-cleaved forebrain. And when you see this, you need to look for other midline abnormalities like a facial cleft, which can be seen in 80% of the cases. We have to look for features of chromosomal abnormality like a trisomy 13. Baby can have a heart abnormality, and the etiology in 50% can be chromosomal, in 20% it can be syndromic, and hence the recurrence risk would be based on the cause of the problem. So if you look at this picture, This is the calvarium, and you can see that the fox is seen at this end, but there is no fox in the frontal region of the baby, and hence there is a fusion of the choroid plexus, and you have a baby with a monoventricular cavity, and hence there is some amount of ventricular dilatation also seen. There is increased fluid inside the brain of the baby. You can see there is no fox here and the forehead portion of the brain. So when you see a baby, when you see the calvarium is intact, now there is no encephaly, there is no cephalocele. You just go inside, look for the fox and the butterfly-shaped choroid plexus. Here, fox is disrupted, and there is a fused choroid plexus seen. And this baby has got a holoprosencephaly, and this should prompt you to refer the patient to a specialist who will be able to see if there are other causes associated with it and offer the patient a genetic evaluation and further genetic testing, because that would enable to counsel them for a subsequent pregnancy. This is a sign that you need to look for inside the brain of the baby. This is a little more advanced beyond this basic assessment. And this is a sign called an obliterated cranial translucency, and it has got a very high sensitivity to rule out neural tube defects. And you don't need to take a different section. You simply need to take the standard mid-sagittal plane that you take for the nuchal measurement. And this is an indirect sign for a baby having an open neural tube defect. This is a standard nuchal translucency image that you can see here. You have the nuchal measurement. Inside the brain, you have 1, 2, and 3 black spaces. Just have it as black and white. 3 black spaces are here, and there are 1, 2, and 3 lines are there. So 3 black spaces and 3 lines, or the third white line is actually the occipital bone. If you see this, then it is normal. You look at comparison here. This baby has got 1, 2 spaces only and 2 white lines only. And this center space is what we call as an intracranial lucency. And here there's an absence of the intracranial lucency. So normally we should see 3 spaces, 3 lines, have 2 spaces and 2 lines. And this is a baby having an absent intracranial lucency. In this baby, it prompted us to look for any neural tube defect, and a transvaginal extended scan was done that identified a very tiny sacral meningocele. This is impossible to identify unless you have a trigger to look for it, and the trigger is a cranial anatomy of an absent intracranial lucency. So we move from the head to the neck of the baby. In the neck of the baby, the common thing is a baby having an increased nuchal fluid collection with cystic spaces, and we call that as a cystic hygroma. It is a bilateral symmetric cystic structure in the occipital cervical region of the neck of the baby. In 80% of the cases, it is associated with hydrops. In 50% of the cases, it can be associated with a chromosomal abnormality, commonly Turner's syndrome. There can be other syndromes like Noonan syndrome in around 40% of the cases. There is a very high risk of fetal demise, close to 90%. Prognosis is poor. If it is isolated and it is a simple chromosomal problem, recurrence risk is low. If it is due to a genetic condition, the recurrence risk is dependent upon the cause. This is the head and the neck of the baby. You can see a large cystic collection behind the neck of the baby with septae. And this can be also seen in the transverse section of the head of the baby. You can see a large nuchal fluid collection with septae. And this is not communicating with inside calvarium of the baby. And this baby incidentally also has got an edema around the baby fully. There's a fluid collection around the lung and the abdomen. And hence, as you can see, this baby has got a condition called hydrops. And hydrops has got a 50 to 60% association with chromosomal problems. So large septated cystic collection, cystic hygroma, most common chromosomal cause, second common genetic syndrome. So you need to offer genetic testing by a karyotype, and then beyond if it is normal, prognosis is not favorable. Then from the neck, we move to the spine. The common abnormality of the spine. you would have seen that the spine is usually seen as two straight lines in the baby, and these two straight lines are seen like this. And when you have a deviation in the in the spine, then you call it as a kyphoscoliosis of the spine. You can see in this particular baby, in this particular baby, you can see that the spine is very, very irregular, and you can see an angulation in the spine that is noted here. And these are spines of a kyphoscoliosis. And again, this is a baby having an absence of regularity of the spine. You can see a very curved spine or a kyphoscoliosis of the spine. This baby also has got a large open neural tube defect. And you can see the cranial signs of a neural tube defect, thoracolumbar brachyschitis, a large open spinal defect. So spine must be two straight lines. You have an angulation significantly like this. We call it a kyphoscoliosis, most commonly associated with open neural tube defects. Sometimes it can be part of a vertebral anomaly alone, and hence, again, a detailed genetic assessment to rule out other genetic causes like spondylocostal dysostosis must be done. So we move on to the other complex problems. From the back, we go to the front, and we need to look for the body wall defects. Normally, we have a complete chest wall and an abdominal wall covering the baby. If there is a large abdominal wall defect associated with an angulated spine, what we saw in the previous baby, and a very short umbilical cord, then we call it as a limb body wall complex. This happens because of failure of closure of the lateral folds of the baby, and this can happen as early as 4 to 7 weeks of gestation. And here, the characteristic sign is because the umbilical cord is very, very short, that it is almost like the baby is attached to the placenta without any interposed structure. The risk of chromosomal problems is not increased. There is no increased risk of recurrence, but it is a lethal problem. Pregnancy needs to be terminated. Herein, you have the kyphoscoliotic spine, you have abdominal wall defect, all structures herniating, the liver, the bowel, herniating out of it. You can see a very short umbilical cord, herniation of the abdominal wall structure, the liver, the bowel outside, and a very short angulated spine. This combination of problems is what we call a body stock anomaly. And you can see the baby is closely hugging the placenta, and that is one characteristic sign here. An extreme condition again is called as a extrophy. Here you have the whole liver of the baby outside, and the bladder of the baby is also exposed outside. Here there is a large anterior abdominal wall defect, and the cystic hygroma is noted. We have seen an abdominal wall defect noted, and these structures are outside. And the zoomed up picture shows you the liver is outside. The liver is outside, the stomach is outside, and the heart of the baby is also outside. This is the other end of the spectrum of body wall defects called serpentology of Cantor. So when you look at the baby, the 12 weeks, you look for covering of the entire chest and the abdominal wall. If there is an abdominal wall defect along with the kyphoscoliotic spine and a short cord, it is called a body stock anomaly. The extreme condition where the chest wall is also deficient and diaphragm is deficient and the heart is also outside, you call it as a pentology of Cantor. So then once we've seen body wall defects, we look for abdominal wall defects. The two most common conditions are an omphalocele and a gastroschisis. This is a midline defect of an incidence of 1 in 3,000 to 5,000. In fetuses before 12 weeks, the liver, the bowel of the baby herniates outside because of the differential growth of the intestines and the abdomen. And by around 12 weeks, the intestines go back inside the abdomen of the baby. So at any point of time prior to 12 weeks, if a small portion of the bowel is outside, it is a physiological omphalocele. we should not report it as a pathology. But if the liver is outside, irrespective of the gestation age, it is called as an omphalocele. Two types, major, minor. Major means size more than 5 centimeter, liver is outside. Minor is a bowel is outside, and a diagnosis always made after the 12th week unless the liver is outside. High association with other problems like heart defects, gastrointestinal, genitourinary tract defects, high association with trisomies and Beckwith-Wiedemann syndrome. BD, as I said, is a physiological herniation. We can differentiate it because of the gestational age and the absence of the liver outside. A limb body wall complex, always associated with a kyphoscoliotic spine and a short cord. An amniotic band syndrome, I will show how the other things are differentiated. And a gastroschisis, where there's an absence of a covering membrane. So this is a baby having a large abdominal wall defect. The whole liver of the baby is outside, and this is best seen in the sagittal plane and also in the transverse plane, where you have a round cyst structure that is right outside the abdomen of the baby. And this is a baby having a minor omphalocele. The whole liver is inside, only a small portion of the bowel is outside, and this is an omphalocele minor. Babies with omphalocele minor have got a higher risk of chromosomal concerns than an omphalocele major. This is not to say that this must be tested. Both fetuses must be tested to rule out chromosomal problems. But babies with omphalocele major have got major surgical correction after birth, which may be stepwise or staged or single. It depends upon the severity of the herniation and the ability to put the contents back inside. Then we have a condition called a gastroschisis, where it is a lateral wall defect. Here, the contents are not herniating to the base of the umbilical cord. These are herniating towards the side of the umbilical cord without any covering membrane. And hence, we have a diagnosis of a baby having a gastroschisis. Here, the assessment is the same. Close monitoring, rule out chromosomal problems. You have to look for any bowel dilatation in the herniated segment, because that can cause complications in the afterbirth. The other condition I already spoke to you about, especially when I was talking about the baby having acrania or abdominal wall defects or limb defect, is an amniotic band syndrome. And why have I put all this? Because the disrupted band can cause a spectrum of malformations. So anytime you have a spectrum of malformations, a baby having a cephalocele or an acrania, along with an omphalocele and hand and foot abnormalities, then it means you have to look for an amniotic band syndrome. As you can see in this baby, you can see freely floating glands. There is a premature rupture of the amniotic membrane, and these are completely in touch with the body part of the baby and causing all these disruption sequences. And this is a lethal problem. Prognosis is poor, especially when the malformations are more, and it has got a sporadic inheritance. Then we move on to little complex problems like the heart abnormality. In the 12-week assessment, you have to look for the presence of the heart of the baby on the left side and two cardiac inflows and two cardiac outflows, what we call the arches. This assessment of the heart of the baby is a basic evaluation at this point of time. So we are not trying to detect complex heart problems, but we're only trying to detect major problems like a baby having an absence of one inflow or an absence for another inflow. A pointer for looking for cardiac defects is a baby having an increased nuchal or cystic hygroma, and counseling and evaluation is based on the primary diagnosis. If you look at this, this is a baby having one inflow and one outflow. The left-sided inflow and the left-sided outflow are very small. Here, this is the left, this is the right. Baby having a smaller right-sided inflow and a smaller right-sided outflow also. This is a comparative, so normal. Two good inflows, only one inflow and a narrower second inflow. Two good outflows. You have one outflow, and here you have outflows has got a different orientation. A similar picture of a cardiac problem. You have a single inflow when you look at color Doppler, and when you push the color down, you have a blue color showing only a single outflow here. So utility of color Doppler will be, you will be able to identify the presence of two inflows and two outflows, but this is difficult and this would need more amount of training to evaluate the problem. Then we come to the bladder of the baby. The bladder must be seen as a small cystic structure in the pelvis of the baby. And sometimes you may not be able to see the bladder during the period of the scan. So it is usually transient. We review after a few hours or a day later. And to assess them, we can use a liberal transvaginal ultrasound. If there is a persistent absence of the bladder, then you try to do a transvaginal scan to look for the kidneys or any abdominal wall defects, or get the patient to be assessed by a specialist. And if the concerns are there, review at 16 weeks to look for the renal or KUB malformations. If there are absent kidneys or hypoplastic kidneys or bladder extrophy, all of these would cause an oligohydramnios by the time, and hence we will be able to clinch our diagnosis. This is a baby having a bilateral, an absent bladder was seen, so an extended assessment to look for the kidneys was noted. Both renal foci were empty, no kidneys on either side, and only adrenals were lying down. And lighter became less as the pregnancy progressed at 16 weeks, and they decided then to terminate the pregnancy. The opposite is a large bladder. This is a much more common finding, an incidence of around 1 in 1500. The number you need to remember is 7, a bladder diameter of more than 7 mm on repeated assessment. I want to reiterate that repeated assessment, because transiently the bladder can be distended and the baby can empty the bladder after that. So if the bladder diameter is above 7 mm, we call it megacystis. And what recent studies show is that if it is less than 12 mm, most likely it will resolve in all the cases. But if it is above 15 mm or 12 to 15 mm, high risk of progression to lower urinary tract obstructions. So this is a baby having a distended bladder at the 12-week scan and a bilateral prominent fluid correction. An option of further assessment was provided, and they reverted back after 2 weeks, and you could see a huge distended bladder with a keyhole sign. This clinched a diagnosis of a bladder outlet obstruction in this baby. So bladder outlet obstructions can be of different types. A chromosomal abnormality can be seen in 1 to 2%, and majority are in a baby of a bladder size 7 to 15 mm. If it is more than 15 mm, as I said, high possibility of a lower urinary tract obstruction, namely a urethral atresia or a PUB, an autopsy picture showing a large bladder and an absence of the urethral orifice, in this case, a baby having a urethral atresia, which is what presents as early as first trimester. A common diagnosis where wrong diagnosis would be a baby having a prune belly syndrome. This is actually not even an ultrasound diagnosis. So what are the numbers we need to remember? Less than 7 mm, okay. 7 to 15 mm, 1 to 2% chance of chromosomal abnormality. More than 15 mm, higher chance of urinary tract obstruction. Babies which are isolated, bladder diameter of less than 12 mm, and when you offer a karyotype is normal. And those that regress before 23 weeks, they have definitely excellent outcomes. Then we come to limb anomalies. Last, babies having skeletal problem. Major skeletal problem can be looked for at this stage. Baby having a very short limbs or an absence of ossification of the bones, usually associated with hydrops, usually as part of a single gene disorder. We need to simply store the DNA, terminate the pregnancy, and look for the fetogram or X-ray and decide on how to counsel them. This is a baby having a very short upper limb, bent bone, both upper and the lower limb. You can look at the autopsy, which shows the same, and the diagnosis was made on the fetogram in this particular case. Limb abnormalities. I have put up this picture to show you that by the time of an embryo age of 56 days, you are having an ossification of the limb buds and development of the upper limb or lower limb 3 segments. So which means you should be able to identify limb anomalies at this stage. Common anomalies you can rule out: absence of the limb, like a baby having an amelia. Here, this baby has got none of the 4 limbs present, or a baby having an ectrodactyly, where a limb has got a splitting or webbing in the middle, or a baby having a transverse limb defect, where a portion of the forearm or up to the hand is not developed at this stage. So all these malformations can be definitely made out by a trans-abdominal or a transvaginal scan if due diligence is made to evaluate the 3 segments of the upper and the lower limbs of the baby. And this is a baby having upper limbs and lower limbs, but both the lower limbs are seeming to be fused to each other and the lighter is normal. This means this baby has got a condition called acidinomelia. A common diagnosis can be easily made out at this time if we simply see both lower limbs not separating out at all. And this babies usually it is associated with a renal agenesis and a bowel obstruction like an anorectal obstruction. And the prognosis for this condition is very, very poor, and it is usually sporadic with a low recurrence risk. At the 12-week scan, we also assess for movement of the baby. If the movement of the baby is not there fully, as is seen here, both upper and lower limbs are simply in clenched position. We call it an akinesia of the baby, varying inheritance patterns. The last and the difficult thing to assess is presence or absence of facial clefts. These may not be detectable in all, and this depends upon the gestational age and the size of the defect. Smaller baby, smaller defect, difficult to identify. Larger baby, close to CRL of 84 or above 13 weeks, and it is a bilateral cleft lip and palate or part of other malformations, easy to identify. These are this is an example of a baby having a bilateral cleft lip palate. Clinching to diagnose is a pre-maxillary protrusion, as you can see here. This is a baby having a midline facial cleft, a gap seen in the pre-maxillary triangle, and this is a baby having a unilateral facial cleft, and you can see the facial cleft on this 3-dimensional rendering image again. So to rule out facial clefts, you look for certain signs: the profile of the baby, to look at the maxilla, and to look at the absence of any protrusion, and the pre-maxillary triangle sign to look at the base to rule out any clefts. So to conclude, this systematic review was published long back in 2013. It says there is a very high detection rate of the first 4 anomalies I showed you, and other anomalies like cardiac anomalies, abdominal wall defects, limb reduction defects have got a varying detection rate. Less detection rate is for spina bifida, dandy walker malformation, arthrogryphosis. But I should say arthrogryphosis can be made out in most babies. However, the detection rate is not 100% because in many it can evolve. But certain anomalies have got 0 detection rate, like a corpus callosal agenesis, a cerebellar hypoplasia, renal abnormalities, lung airway malformations, a duodenal atresia, because by embryogenesis, these problems present only in the 2nd trimester of the baby. So there is a 100% detection rate for these 4 anomalies. The other anomalies, the detection rate is little lesser. A systematic assessment, if it is done from the head to foot of the baby, will help you differentiate the normal from the abnormal appearances. Thank you so much.
Thank you, Dr. Sudarshan.
Thank you, sir, for your elaborative session. Thank you very much.
Can we move on to the
Thank you.
presentation, Mindray presentation, and then we'll have questions, and then we'll go to the last session.
Okay, sir. Shivangi, sir, you need to stop sharing your screen.
Yeah, I'm trying to do that. Give me a second.
Running out of time, so we have to be very quick.
Sir.
Yeah, Shivangi, can you try your presentation, or else I will play for you?
Yeah, I can see it now. Yes. So can you all see my presentation?
Yeah, we can see very much. Please go ahead. Yeah.
Okay, yeah. So today I would like to introduce one of the Mindray new feature, Smart Scene 3D. So 3D 4D has become a very integral part of our OBGYN imaging. Earlier, we used to use it only for facial anomalies, but now we are using it for fetal CNS abnormalities also, for fetal cardiac also, as well as for fetal spine and other long bone abnormalities also. When we talk about gynec imaging, we are using 3D 4D for many applications like ovarian cyst and ovarian follicles. Also, we use it for endometrial lining and other endometrial abnormalities, as well as we use it for pelvic floor imaging also. So, in general, doctors find 3D 4D very, very difficult because of certain challenges that we face while acquiring 3D 4D. The biggest challenge that we face is first the ROI box adjustment. For each and every examination, we need to have a different settings in the machine. And this requires experience. Second challenge that we face is the rendered mode selection. For each imaging type, we need different rendered mode. And all machines have this rendered mode selection option available, like surface, minimum, maximum, or X-ray mode. Also, the third difficulty that we face is the volume calculation. For a single calculation, we need to take multiple manual measurements to get the required volume analysis. And for all this, the one imaging, because of all these challenges, to image or to complete one study, each doctor needs to spend a lot of time for 3D 4D imaging. And to give solution to all these challenges of 3D 4D, we have this option that is Smart Scene 3D. It is a very unique solution, and it is artificial intelligence based solution which makes your 3D 4D imaging extremely easy and user friendly. Now let's see what it does. So it is a completely automated tool which gives you volume scan images on a scenario oriented or a scenario based solution. So it gives you a solution based on organ specific imaging. So in this, you don't need to do any manual settings. Machine is customized to give you specific solution for all your 3D 4D needs, like fetal brain, fetal face, fetal spine, fetal long bones, endometrium, as well as your pelvic floor imaging. This single tool will adjust your ROI box automatically. It will select appropriate rendered mode. It will also select advanced planes for from your 3D 4D basic data, raw data, as well as it will automatically do the volume calculations also. So let's see little bit in detail, like for fetal brain, once you take your BPD plane and select Smart Scene 3D, machine will automatically adjust your ROI box, select the appropriate rendered mode, load Smart Plane CNS to give you all 4 fetal CNS planes like TCP, TTP, TVP, as well as MSP, and it will give you all the measurements for fetal CNS. So your complete fetal CNS study will be completed within 1 minute, and you don't need to do any adjustments or don't need to press any other button. Similarly, the same tool adjusts your ROI box, selects your rendered mode, and acquires the image for fetal face, similarly for fetal spine, as well as for fetal long bones. So it makes your 3D 4D for OB imaging very, very easy. Just like fetal CNS study, we have a complete acquisition tool available for pelvic floor also, where apart from ROI adjustment, machine will select rendered mode. It will do the orient your 3D image in such a way that you can nicely see the pelvic floor and levator hiatus muscle, as well as it will give you the automated calculation for levator hiatus muscle also. And you can do the multi-slicing also along with it to give you more advanced study. So what are the, similarly, we have a complete tool available for endometrium imaging also, along with the endometrial volume calculation. What are the clinical benefits for it? So just like 2D imaging, where we make dedicated presets for each and every examination, if we have similar presets available for 3D, 4D imaging also, it will make our life very, very simple, and it will increase the diagnostic confidence and the clarity of our 3D, 4D image also. Second is we have consistent preset for each and every examination, and we don't need to do manual adjustments for each and every patient. And third, it makes your workflow extremely easy. You don't need to remember settings or how you can optimize your images. Everything is done by machine to make your work and 3D, 4D very, very easy. So here I would like to present Mindray Smart Scene 3D solution, which is a unique artificial intelligence based solution to make 3D, 4D easy and help you in your daily practice. Thank you very much.
Thank you so much, Shivangi. Over to you, ma'am.
Okay, are there any quick questions to be? Can we answer some questions before?
Should I take my question?
Yes, somebody should read the questions. No, I thought somebody was handling the questions.
So there is a question.
Surekha is there, na?
Yes.
Yeah.
Can BPD be measured at the transventricular level in 11 to 14 week scan?
Yes, there is a study done by the group of Professor Eris Papagiorgio when they did the intergrowth study, and they have seen that all head measurements can be taken when they are taken either at the level of transventricular or the transthalamic plane. The variability is not very significant. So head measurements can be taken at any gestational age, even at the transventricular plane, without much variability.
Thank you. Next question is how we delineate a corpus luteal cyst and hemorrhagic cyst?
I think are we doing it today or part of gynec?
So I could do it in a minute.
Yeah, go ahead.
I'll just, if it's possible, share the screen. I have kept the image ready. So if you can see the screen, this is just a video clip showing you what a hemorrhagic cyst looks like. You can see I'm just gently tapping the cyst, and you can see the movement of the echogenic fibrin strands within the cyst. So this is what a hemorrhagic cyst looks like. And the clincher would be this image. When you would put color Doppler, you would not see any vascularity in this solid component in a hemorrhagic cyst, nor would you see any peripheral vascularity, which is seen with a corpus luteal cyst. Remember, corpus luteal cyst has the peripheral ring of fire. So this is a hemorrhagic cyst. If it would be a hemorrhagic corpus luteal cyst, it would show you a peripheral ring of fire.
Okay. Next question is significance of the amniotic band at 11 to 14 weeks.
Sudarshan there.
What is this?
Okay, so significance of amniotic band at 11 to 14 weeks. Yeah. So,
Can I have the question, please?
yes. Significance of amniotic band at 11 to 14 weeks.
Okay. So at the 11 to 14 weeks time, the amniotic membrane will be usually loosely seen in the cavity. It is not fused with the chorionic cavity. The problems happen when there is a disruption of the amniotic membrane, and you see loose strands closely attached to the body parts of the baby, like to the limbs, the abdominal wall, the head, and these may cause disruption sequence. So if during the development the amniotic band is impinging on the calvarium, it can cause a calvarial defect or a cephalocele. If it impinges on the abdominal wall, it can cause an abdominal wall defect, and so on and so forth.
Okay. Next question is how to measure G-sac diameter accurately. Many times my measurements come
Usha.
less than gestational age.
Usha there? Usha. Okay. If Usha is not, yeah.
I'm there, sir.
Yeah.
So
please.
to measure the gestational sac, you have to get the gestational sac in the first, you get it in the maximum diameter. So from there, you will get the longest and the anteroposterior diameter. Then we will rotate the probe 90 degrees so that you get the transverse section. So, and you will measure the transverse diameter over there. We will not include the chorionic rim in that. So you will take from inner to inner. And after having all three measurements, you add all three and divide it by 3. But please remember that we don't use this for dating of pregnancy, only to plan our next visit, if at all we have a doubt about the viability of the pregnancy.
Also, all these measurements are transvaginal. If a transabdominal is too full of bladder, then the
Shape it may
sac
be
can get
altered.
distorted. Yeah.
Next question is, what is exactly intracranial translucency?
What is?
You want me, or sir, would you like to? Dr. Sudarshan, would you like to answer this? Or?
No, you can take the question. No problem. It's the same.
Intracranial translucency, as I mentioned earlier, is this anechoic space, which it's actually the 4th ventricle. Intracranial translucency is the 4th ventricle in the first trimester, and it is seen as a anechoic space between the brainstem anteriorly and the cisterna magna posteriorly. If you want, I can show you the image again for clarification. This is just an image, and you can see here, this is the brainstem. This thing, which you see behind the brainstem, this is the intracranial translucency, and it corresponds to the 4th ventricle. And this is the cisterna magna behind.
Okay, ma'am.
Okay, so the next question is accurate measurement of abdominal girth. How to measure?
Abdominal circumference is measured at the level of the plane for the abdominal circumference. I'm sure that will be discussed in the subsequent presentation.
Yeah, the next presentation.
Okay, so that was the last question. And shall we move ahead, sir? There is no more questions, so we can start the next lecture.
Yeah, I'm ready.
Okay, so now I invite Dr. Suresh for the next lecture on the step approach to basic obstetric scanning. Over to you, sir.
Okay. Just give me 1 second. Okay, something is getting stuck here. Give me 1 second. Give me 1 second. I think something is getting stuck here. Not loading. I think I'm going to reboot again. I'll rejoin. Give me 1 second.
Sir, meanwhile, can we take some questions?
I think so, Dr. Unnati. You can ask the questions.
Okay. Yeah. So this question is for Dr. Divya. Dr. Divya? Okay, Dr. Divya has lost the link. Okay. Dr. Sudarshan, are you there?
Yeah, NT can be measured by TVS, but it is a little bit difficult to do your manipulations through TVS. So in case if you are really not able to do it with the transabdominal scan, probably we can do it through TVS if it is accessible to us.
Okay. The next question is echogenic focus in left ventricle in heart. Does it carry any significance?
I think that also will be covered a little later.
Yeah.
So yeah. And Dr. Divya has joined. So I answered the question whether we can do it by transit. Yeah.
Thank you so much.
Are you able to see my screen?
Yes, sir.
Yes.
Okay, sorry for the suddenly the computer hanged. Okay, so we've had 3 very important lectures: the early pregnancy scan, the 11 to 14 week scan. I'm going to take you through what we call as a 6-step approach to the obstetric scan. We are getting more into the practical aspect of doing the basic scan. The 6-step approach actually helps you to identify fetal lie, placental localization, amniotic fluid volume. This is all that, and also fetal biometry, basic biometric measurements are done here. So what we would like to know is, how do you move your probe? What probe sequences you need to use to identify fetal lie and presentation, the number of fetuses, placental site and amniotic fluid volume, and also how to do the basic biometry. Now, obstetric ultrasound has its own challenges because it is completely operator dependent. Unlike CT scan or MRI, which you send the patient through the machine, you get slices and then you can work on the slices offline. Here it is almost real-time diagnosis which we need to make. There is also changing fetal anatomy with gestational age. So the anatomy which you see at 12 weeks is different when you see at 20 weeks and maybe different when you see at 30 weeks. Also the visibility during the scan, like fetal movements, high BMI, fetal position, all these can impair visibility and can be very troublesome sometimes. Supposing persistently spine is posterior, then you may not be able to evaluate the fetal spine. There's also shadowing of target abdominal organs. So if the fetus hand is kept right in front of the face all the time, then you can have shadowing which might fall on the face and you might think there's an absent nasal bone when there, or a cleft palate, for example, when actually there's nothing there. So these are some very big challenges which we have. So what we require is a very standardized approach. We want to minimize the ultrasound steps. We want to be telling us we'll do specific sections and we will stick to those sections all the time and get the information we want. We should also try to introduce consistency in image acquisition and interpretation. So imagine ourselves doing a CT scan or an MRI, go for only specific sections. Only thing is you place your probe in such a way that you'll get those specific sections and then you document them and then you can interpret them. This allows for a very efficient examination. It shortens the learning curve and also provides a path to automation. So what are these 6 steps? Alfred Abu Ahmad published this about in the year 2016. He said when somebody wants to do a scan, first you do presentation and lie. Then you detect cardiac activity. Then you look at number of fetuses in the uterus, determine and locate the position of the placenta, estimate amniotic fluid, and do biometric measurements. This is called as a 6-step approach. Now, From the presentation and lie, we can actually identify which is the right side and left side of the baby. From the number of fetuses, it's extremely important we identify chorionicity. And in the determination of location and position, we not only try to look at placenta previa and increasingly we placenta accreta, because a lot of patients come with previous cesareans, previous DNCs. So we'd like to exclude placenta accreta in all of these high-risk patients. Now, the Mediscan approach is slightly different. We have what is known as a 7+3 = 10 approach, which actually means there are 7 steps to the obstetric scan. That is, we emphasize a lot on history taking, because from the history, we know why the patient has come for scan and what is the question we need to answer for the scan. Second is the survey. Third is the biometry. Fourth step is the targeted scan. Fifth step is fetal activity, fetal environment, and reporting. And then when you do the targeted scan, we look at 3 anatomical planes in each part of the fetus. And each of those 3 anatomical planes, we look at 3 things so that it is easy to remember. And remember, 10 is the outer limit of normal for measurements of lateral ventricle, renal pelvis, cisterna magna, etc., beyond which you're supposed to escalate it to the next level. However, let me take you through the 6-step approach and how it is done. Step 1 is fetal presentation and lie. So we always place the transducer transversely in the lower abdomen. And then the reason why we do that is we want to know what part of the fetus is lying down there. And then you just need to move the probe up and down, just down and up till you identify the fetal part. So if you find the head there, then it is cephalic presentation. If you find the breech, of course, it's breech presentation. And if you don't find anything, it is transverse or oblique lie. So just in 2 seconds, you can know what is the presentation. You can not only know that by just moving the probe, you can find out which side of the baby the spine is, and you can find out the right and left side of the baby. The next thing to do is to identify fetal cardiac activity. Now, cardiac activity is done again. Imagine the uterus is a place where it's an enclosed space where you're not able to look directly. So you're using the ultrasound as a torchlight to look into it. So you use your probe. By moving your probe systematically, consistently in the same manner, you will not make any errors or mistakes. So for determining cardiac activity, we start off transversely above the pubic symphysis, move your probe upwards till you find, if you don't find any cardiac activity here, then you move it to the right or move it to the left till you find. And if you find the fetal thorax and you don't find cardiac activity, then of course, you can declare it as an intrauterine device. So here you can see the probe moving like that. We will see it in the demo. The next step is to look at the number of fetuses. Number of fetuses can be a challenge because if you can make potentially a mistake in the number of fetuses. We have had several instances where a singleton has been called as twins and a twin pregnancy has been called as singleton. Sometimes triplets and quadruplets. The higher the number, the more chances of missing one fetus. So in order not to miss it, imagine the whole uterus. You need to divide it into compartments, longitudinally and transversely. And you ensure that your probe traverses all these areas so that the length and the breadth of the uterus are covered. So start off here, move up, can come back here, move up, come back here, move up. And then you rotate your probe 90 degrees, put it vertical, move this side and move this side. And then for locating the placenta, which is step 4. When locating the placenta, you start at the fundus. The most important thing is your probe should be absolutely perpendicular to the couch, right? You don't angulate the probe. While looking at number and also locate the placenta, you never angulate the probe. If you angulate the probe, you'll be looking at a wrong location instead of looking directly downward. The whole idea is you want to look directly down to where the probe is facing and just cover the longitudinally from the fundus to the cervix, from the fundus to the cervix, from the fundus to the cervix. This is all required to locate the placenta there as we are moving now, right? So if the placenta is anterior or posterior or so here is a placenta which is fundus, anterior and posterior. It's a fundal placenta extending anteriorly and posteriorly. Here is a completely anterior placenta and here is the placenta which is coming close to the internal os. So the important thing here is to go and look at the lower edge of the placenta. Wherever the placenta is, the lower edge must be marked and you need to say the lower edge is far away from the cervix or closer to the cervix. And the placental edge less than 2 centimeters from the internal os is called as low-lying placenta. The fifth step is the estimation of amniotic fluid. Now, amniotic fluid estimation, you need to actually scan the entire length and breadth of the uterus to know where all fluid pockets are there. On a subjective assessment, you can find out there may be some areas where there may be more fluid, some areas may be less fluid. So you need to identify which is the largest pocket of fluid and for us to do the measurement. The other measurement is called as the 4-quadrant measurement. You divide the uterus into 4 quadrants and then each quadrant you go from the midline laterally to ensure you identify the deepest pool in that quadrant. So deepest pool in all the 4 quadrants are measured and you ensure there are no fetal parts inside or umbilical cord which comes inside, and then measure the deepest vertical pool. So 3 methods: subjective, maximum vertical pool, and amniotic fluid index. Amniotic fluid index is just to add all the 4 numbers, but as you'd say that the single deepest vertical pool is probably a better method, because in the second trimester it is difficult to divide the uterus into 4 quadrants. When you place the probe may be encroaching on the other quadrant already, and you may be measuring the same pocket of like a second time also. So the maximum vertical pool less than 2 centimeters is oligohydramnios and greater than 8 centimeters is polyhydramnios, and an amniotic fluid index 4 quadrant less than 5 is severe oligo and greater than 20 is polyhydramnios. So here is a 4 quadrant measurement. Here you can see there's no Leica pocket here, no Leica pocket here. And when you see an apparent pocket, it's very important to switch on the color Doppler so that you have to exclude an umbilical cord being present there. Sometimes the umbilical cord can be there, and if the ultrasound beam is going parallel to the cord, you will look like an amniotic fluid pocket when actually it is not. So here you can see a single deepest vertical pool of 3.3 centimeters. So obviously this is oligohydramnios. So measure the 4 quadrants, pockets in 4 quadrants, and you add. Maximum pocket is the pocket that has the most fluid. Actually, this is more indicative of oligohydramnios and avoids unnecessary interventions. If you use the maximum vertical pool versus the AFI, maximum vertical pool is actually better. Now, you need to keep in mind that to get the maximum vertical pool, you have to scan the uterus in all 4 quadrants. So you're looking at amniotic fluid evaluation anyway. But as I said, it's simpler to use the single deepest pool. But very important to know there are some common errors of measurement of amniotic fluid. Here somebody has measured, you can see the reverberation artifacts here, and from the anterior wall to the posterior wall is actually here. So this is the wrong measurement. Again, here the umbilical cord has come in the middle and you have measured from the anterior wall up to the umbilical cord. Here again, the caliper is not touching the anterior uterine wall. And here is very important. The gain control of the machine is very important for measuring amniotic fluid. Here is a image taken at a low gain control, and they have measured the amniotic fluid from here to here. Here is the fetal part, and here is what they thought was a membrane there. But little bit increase in the gain will tell you that this is actually reverberation artifact and it's a completely wrong measurement. So this is very important to understand. The last step, of course, is the biometric measurements, which is biparietal diameter, head circumference, abdominal circumference, femur length. These are the basic measurements. We can do extended measurements like transcerebellar diameter and lateral ventricular measurement. Now, once you do the biometry, there are two reasons why you do the biometry in the second trimester. If a first trimester scan has not been done, you use the biometry to date the pregnancy. And while you use the biometry, we use the head circumference for dating. That will come in another lecture anyway. So it is just to tell you the important thing is to know accurately how to take biometric measurements, which is what we will see during your video demonstration. Now, these are the 6 steps of the basic examination. You have to remember that these steps hold good for both the second trimester and third trimester. It's been designed that way. So the targeted scan does not come in the 6th step. The targeted scan is a separate step by itself altogether. So these are 6 steps meant to screen the patient for presentation, lie, number, and amniotic fluid and cardiac activity. So they did a study on how long does it take, and it takes about 268 seconds plus or minus 64. That's about, let's say, about 330 seconds, which is about 5 minutes and 5.5 minutes. So it takes about 5.5 minutes to do all these 6 steps, and it's better that you do it in this manner so that your time of examination can actually be reduced. And secondly, there is no uncertainty of your findings. When you go according to these steps and document, you will find that you will be able to consistently give a better report. Okay, so the key points are ultrasound examination in the second and third trimester should be approached systematically. The sequence is fetal presentation, heartbeat, number of fetuses, placental position, amniotic fluid estimation, and biometry. Standardization enhances confidence in the trainees. So we will stop here, and then we can move on to the virtual demo. Okay, what I'm going to do is it's getting a patient to actually demonstrate and do a recording is becoming increasingly difficult. Secondly, when you want to start learning hands-on, it's much easier to learn on a simulator. And today we have technology that actually allows you to learn from a simulator, not necessarily in your own center, but across the continents. So it is possible to do that. So what I have done is I've done a recording on a simulator, which I'll play it for you now, and then we can discuss about it. This is a 6-step approach.
Sir, please unmute.
Are you not able to hear?
Sir, we couldn't hear anything from the video demo.
Oh, really?
Yes, sir.
Okay. 1 minute. How's that? 1 minute. Why are you not able to hear? I'm able to hear it very well. 1 second.
The first step is
Are you able to hear it now?
to identify
Yes, sir.
presentation and slide. For this, what I would like to do,
Sorry.
my people presentation and slide. Vinny, are you ready? Okay. So let's go through the 6 steps as we have described in the lecture. The first step is going to be to identify people presentation and slide. For this, what I would like you to do is to place your probe horizontally just above the cubic surfaces and slightly angulate the probe downwards and upwards to see the presenting part. And as you observe the presenting part, I can see the bladder. Obviously, it's a big presentation, and the spine is to the mother's spine. So, in other words, this baby, I'm seeing a cross section of the spine. That means this baby is lying longitudinally on the abdomen with the breech presentation and the spine to the mother's spine. So let's move on to step number 2. So that step number 2, I'm going to look for cardiac activity. I'm going to ask Minnie, can you move the probe horizontally as you go up towards the umbilicus? As you're moving, you're surveying the uterus. I'm watching for presence of cardiac activity. Keep moving. Okay, now I've come to the heart. Can you stop there? I can see cardiac activity there. So I demonstrated cardiac activity using the light meters. So then I don't need to go further. I need to come back again to my original position. In case, when you come back to original position, in case I don't see the heart here, then I will move the probe to the right of the mother and keep moving to look for a cardiac activity. So again, I can see the cardiac activity. Or I can move to the left of the mother and watch for cardiac activity. So in any one of these 3 moves, you will be able to see cardiac activity, and we can say that this feature is alive. So step 2, cardiac activity is over. Let's move on to the 3rd step. The 3rd step is to understand the number of fetuses. Now, please understand that with the probe, we are actually seeing small portions of uterus at a time. And if you really want to know the number of fetuses, you must scan the entire length and breadth of the uterus. So how do we do that? We will first start horizontally towards the right of the mother, and then move my probe upwards all the way up to the fundus. As I'm watching, move more to the right. As I'm watching, I'm actually looking at one fetus. I'm seeing the head of the baby there. So let me come down and then move to the midline. From the midline, I keep moving the probe upwards. Again, I'm seeing only one fetus, the same fetus again. And I move up to the left and move again to the same activity. So deliberately, I'm just moving my probe 1, 2, 3. That's what I cover the entire length of the uterus. Now let's look at it in the opposite direction. That is, I rotate my probe 90 degrees, come to the right of the mother, and then move my probe towards the left of the mother. I can see the longitudinal aspect of the fetus there, one fetus coming there. And as I come down, go back to the right side, and then I move my probe again, doing exactly the same thing. So by doing these 5 maneuvers, I have covered the uterus transversely and I have also covered the uterus longitudinally. And I have come to the conclusion there's only a single fetus there. So step number 3 is over. So we have seen first step is fetal life, second step is fetal cardiac activity, third is number of fetuses, and then we go on to the fourth step. The fourth step is location of the placenta. A very important thing before I look at the placenta is your probe should always be vertical or perpendicular to the couch. The probe should always be perpendicular to the couch, and that's very important. Then I come to the right of the mother, go to the fundus of the uterus as you can see here, and I keep moving down. Straight I keep moving down. And I find there's really no placenta anywhere, anterior wall and posterior wall. So again I go back to the fundus, move slightly to the midline, and as I'm coming down, I can watch the placenta. Can you stop there, please? Can you stop there? So now I can see the placenta, and this placenta, I can see the upper edge of the placenta in the fundus, and then the lower edge of placenta in the anterior wall. And it's important for me to move down and watch the lower edge of the placenta and keep moving down till I come to the cervix. Here, I can see the cervix now. Stop that please. Once I see the cervix, the lower edge of the placenta and the cervix are very far away, so the placenta is very high. Now, if the placental edge is less than 2 centimeters from the internal os, then I will call it as a low-lying placenta, and if the placenta is covering the os, I will call it as a placenta previa. So we have finished the location of the placenta here, and then let's go to step number 5. Now, step number 5 is estimation of amniotic fluid. Now, you should realize that the amniotic cavity contains the amniotic fluid, the fetus, the umbilical cord, and the other fetal parts. It's important for us when we measure the amniotic fluid. There are 3 ways of measuring amniotic fluid. One is the subjective method. I will just move around the probe, come to the midline, and go up. So just looking around to see that there is enough fluid around the baby. That's my subjective assessment. But if I want to do an objective measurement, I have 2 methods again. One is I measure all the 4 quadrants. Come to the right side, please. So again, I keep my probe perpendicular to the couch. So I'm seeing the right lower quadrant. So I can actually make a measurement at this point of time. And then I move to the left. And here I can see a larger pool. And I must ensure that I avoid the umbilical cord and the fetal part. Right? And then I go upwards. I can go up to the next quadrant. Again, I look at, you can see a large pocket here. I can freeze the image there. Can you freeze the image? Can you make a measurement at this point? So in each of these quadrants, if you make a measurement, then you can get the amniotic fluid index. However, in the second trimester, we try to measure the single deepest vertical pool, and this holds good even in the third trimester. Right. So that's good. So any amniotic fluid, single deepest pool is less than 2 centimeters or more than 8 centimeters per moment. Now you can decrease and go to the last pocket. So before you make an actual measurement, you look all around and look for the deepest vertical pool. So obviously, physically looking at it, you can see among all the 4 quadrants, the quadrant which we measured, there which is the left of the quadrant, had the maximum vertical pool. Next, we come to the last step. The last step is looking at biometric measurements. So when you want to do biometric measurements, we are going to do biparietal diameter, head circumference, abdominal circumference, and femur length. That is the routine biometric. So for getting the head circumference, I want to trace the spine of the baby. And once I get to the spine of the baby, spine means I'm getting the cervical spine close to the occiput. I can either get a longitudinal section or I can get a coronal section like this. Now I just rotate my probe 90 degrees and keep going upwards till I reach the head, and there I am looking at the transthalamic. Can you stop there? Can you stop that, please? So that's the transthalamic plane. You can see the two thalamine, which is brought out very well. Can you see the image? Now I can measure the biparietal diameter and set circumference at this level. So for this, I need to zoom the image. I need to zoom the image, and then what I'm going to do, I'm going to ask Winnie to give me control so that I can do the measure. Can I do that? So, okay, I got the biparietal measure. I'm going to do the outer two inner measurement, making sure that I am exactly perpendicular to the box. Right? I got the measurement there. Then I will go and measure the head circumference or the occipitofrontal diameter. So that's my occipitofrontal diameter. In this, I measure outer along the fox cerebri. Okay, measure the occipitofrontal diameter, and the head circumference is automatically calculated. I can also use the ellipse to get the head circumference. Okay, when I do the head circumference, I start off from the occipitofrontal, and once I get here, so I'll do that, and then I'll adjust it such that it is fitting the head. So I measure the head circumference. So two methods of measuring head circumference, either the PPD OFD method or the ellipse method. I think this is important. So here, just for you to understand where we have placed the probe on the fetus. So that's your biparietal diameter, and we have moved the probe so that we get the transthalamic plane. So let's go on to the next measurement, which is the abdominal circumference. Now, Vinny, can you actually unfreeze? Can you unfreeze and show us where you started off with, right? Can you? There. So you started off with your cervical spine and occiput, correct? Then you rotated the probe 90 degrees. And angulated it so that you get to the thoracic plane. Very good. Excellent. That's perfect. So now let's go to get back the mother again. Get back the mother again. Now, so we got the mother again. We are going to now measure abdominal circumference. So we know that the fetus is in breech presentation. The breech is down, and the spine is to the mother's right side. Right? So I go to I can go to the longitudinal section of the fetus or the coronal section of the fetus. That's the posterior coronal section. I will come slowly towards the left of the mother to get the abdominal section. Yes, little bit more, little bit more. Perfect. Now at this point of time, I'd like to rotate my probe 90 degrees till I get, that's the heart, then I come down to the abdomen, there. When I see the umbilical vein, I come to a point where the umbilical vein is not entering not touching the abdominal wall. It should go, yes. Can you stop that, please? So it's important You can see the image. So it's important to know that, can you zoom the image now? Yes. Now I can get outer to outer. So the spine should be round. Let me take hold of the measurement. The abdominal circumference is here. So I'm going to do the ellipse method. Outer to outer. You have to be very sure. Perfect. So the abdominal circumference has been measured, right? So this is the important thing here is you must see the stomach. You should not see the kidneys, and you should ensure that the C curve of the portal weight is there and the spine is absolutely transferred. So let's go on to the femur length. Now the femur length, it's very easy from here because in the transverse section you keep moving down the fetus. Now when you come to the bladder, just outside the bladder you are seeing a small dot. You can see the pelvic bones, and just beyond that there's a small dot, and that's the femur. So at that point of time, I want to rotate the probe, and angulate it slightly so that I get the entire femur. There's a bit of angulation and rotation. Perfect, perfect. You can stop there. So that's your femur length. So let's get the femur length done. So I got the femur length done, right? So with this, our biometric measurements are over, but I would like to show you where we have placed the probe. So can you take away the mother and show the fetus alone? Right. So can you zoom the image, please? Right. So you can see how the ultrasound beam is actually going through the long axis of the femur. So we started off in a coronal plane here, and then we moved forwards. And after moving forward, we rotated the probe so that the long axis of the femur is seen. Okay. Thank you. Now the basic 6 steps are over. I'm going to show you 2 important things. One, additional biometry. One is the transcerebellar diameter. And I think it's important that we should know the transcerebellar diameter. Can you go back to the mother? No need. I think you can be here itself. You can be here itself without the mother, because we've already seen the head. Go to the head. Go to the head. Go up to the head. And as you go up, you can see down. If you can show the baby, yes. So what I've done is the beam is angulated slightly towards the occiput. As she's angulating slightly towards the occiput, you can see the cerebellum coming up. Okay, there. Perfect. Stop, please. Stop. Can you zoom? The zooming is extremely important for all biometric measurements. And then I'm going to use the caliper. I'm going to get the outermost to the outermost bicerebellar diameter. Okay, the last thing now we'd like to show you is the lateral ventricle measurement. So can you see please, and then let's go to the transventricular plane. This is the transventricular plane. Can you stop that please? Can you increase the gain a little bit? Yes, that's very nice. That's very nice. So now I can see the lateral ventricle. So I'm going to take a measurement. I'm going to use the inner to inner measurement of the lateral ventricle. at the level of the globus of the correct plexus. And at this point, you will also see the pareto occipital be surveyed. Okay, so we have completed the biometric measurements, the common biometric measurements. So with this, we come to the end of the demonstration of the 6-step approach with a little bit of extended biometry of the cerebellar diameter and the lateral ventricular measurement. Thank you, Vinny, and thanks.
Okay, so we have gone through the 6-step approach. And let's show you the next demonstration of, about the measurement of the crown rump length.
Let's come to demonstration of 11 to 14 meter cat. In that, one of the important measurements we want to take is the crown rump length. So Catherine here is 12 weeks pregnant now. So we are going to ask Vinny to scan the baby and try to help us. So please place your probe horizontally above the pubic symphysis.
Hello.
Hello, sir. Not audible.
Now it's audible.
Please place your probe horizontally above the pubic symphysis as we usually do. Keep moving up till you come and see the uterus. And okay, I'm seeing the baby there. And what I'm seeing is I'm head, the trunk, and also the lower limbs. But for me to measure the crown rump length, I need the baby in a horizontal position. Can you angulate your probe so that the fetus comes horizontal on the screen? Just rock the probe. Yes, that's good. That's the way I want to go. Now go up, or come down, depending on where the fetus is. Yes. So can you get us the longest length of the fetus now? Keep rotating. Yes, you're nearly there. Yes, I can see the rump very well now. Yes. Can you freeze that? Can you freeze? Okay. Can you zoom the image? So I get a mixed sagittal section of the fetus. And then I try to identify the rump and the crown so that I get a good mixed sagittal view. And then I'm going to start measuring them. And I have control for measurement? Yeah. So here is the caliper. So I would actually prefer the fetus to be a little bit more horizontal on the screen. This is a vertical fetus. I would like to rotate so that the fetus is more horizontal on the screen. Okay. Now, is it possible for us to do in this? The plane is all right. We just have to ensure. Yes, you can see now the fetus is much more horizontal. That's perfect. A little bit more. Yes. Yeah. You can see the orbit is there. That means you are parasagittal. I would like to take away the orbit. Yes, perfect. There you got it. Yes, stop it. Yeah. So this is fine. So it's a little bit more horizontal and we can measure from here to here. Right.
3D. Okay, so we have seen the ground rumpling. I'll just take you through a couple of anomalies which you can see in the first trimester.
Well, weeks pregnant, I'd like to scan the fetus. The ground rumpling has already been taken. So I'd like to know the fetal normalcy of fetal anatomy. So as I'm moving the probe, scanning through the uterus, go all the way up to the fundus. So I'm starting off saying there's only a single fetus here. And that's the head. I can see the mid-sectional view of the face. I'd like to zoom the image, please. Yes, that's good. So cardiac activity is present. That's the spine. I can see the nasal transparency and also see the amnion, which is surrounding the baby. As I come close to the head, I am seeing a small little projection which is coming out of the skull. A very small, tiny projection, which I think is a capillocele. But I have to reconfirm this by doing a transverse section of the head. So can you move the probe so that I can get a transverse section of the head? Yes. There you are. So as I'm getting you the transverse section, you can see the small capillocele is projecting out. There's communication with the intracranial cavity. So it's very important that when I find an anomaly, I should try to scan it in two planes so that I can reproduce the same finding and confirm that it is not an artifact, but indeed a true finding. So this is a case of a capillocele at 12 weeks.
Okay. The last one.
Thank you.
This will be the last one. Then we will discuss.
12 weeks pregnant, I'd like to scan the fetus. The ground rumpling has already been taken. So I'd like to know the fetal normalcy of fetal anatomy. So as I'm moving the probe, scanning through the uterus, I go all the way up to the fundus. So I am starting off with saying there's only a single fetus here. And
Sorry. This one.
Okay, let's now take another patient who is also in the first trimester, around 12 weeks, and the patient has been referred for evaluating and doing the first trimester scan. So, can you scan the patient and show me? I'd like to zoom the image, please. Okay, so again, I'm starting off with the survey scan, telling that there's a single fetus there. Okay, that's the upper limb, lower limb. You can see the ribs. As I come down, the fetus is lying horizontally. And as I move, can I show the head? Can it show me the head? Yes. So the head seems to be all right. The skull is intact. I can see the nasal bone, the maxilla, and the mandible. I come to the spine. Spine appears intact. You can see the nuchal line which is coming down. There's space between the chin and the chest. And I can see the fetal hand with the fingers there. Cardiac activity is seen in the lower limb. Okay, that's the lower limb, which is all right. Can I come down back to the abdomen, please? So in the abdomen, I'm seeing in the lower abdomen there's a large cystic area. And obviously, it is in the midline. It is the midline. So I would like to rotate my probe and do a transverse section of the structure. Rotate the probe. Yes. Nicely. So you can start the transfer section from the top of the fetus. You can come down from the head and go to the head. Go up. Yes. Go. Yeah. So now I'm actually going from the head, come down. Come down. Face up to upper limb. Then when I come down to the pelvis, you can see the pelvic bone, and in between the two pelvic bones, there's a midline cystic structure, which is quite large. I think it's a megacystis.
The bladder diameter of 7 to 15 millimeters indicates a risk of aneuploidy.
And more than 15 millimeters is considered as possibly due to obstruction. But whenever you see a megacystis, then you have to do further investigation. Thank you.
Okay, so we come to the end of this demonstration, and I want you to understand a very important message I gave in the last scan. Is as I was scanning, I saw a big bladder right in the very beginning, but I did not go and look at the bladder. I looked at all the other parts of the fetus and came to the bladder finally. This is very important when you do a scan. When you see something obviously abnormal, please do not go and start scanning that part, because if you concentrate on that part, other parts of the fetus which are normal will be left behind. You lose out on your checklist. So go systematically according to your standard checklist, and then finally you already made note that something abnormal there, but come to it at the very end. Don't go in the beginning, because then you'll have a lot of time to concentrate on the anomaly, because you have finished off all your normal work that needs to be done. This is how we do in our day-to-day life. Finish off all the things and you have something something exclusive to do. So finish off everything and sit with it and then work on it. Then you're much more efficient doing that. So thank you. And any other questions are there? We'll do that. I think we are.
Thank you, sir. Thank you for that lucid presentation. We have 7 more questions in the box. So the first question is accurate measurement of abdominal girth.
Yes, I've shown you the measurement of abdominal girth. It's always outer to outer. There are 2 methods of doing abdominal circumference. One is the diameter method. You take the 2 diameters, outer to outer, outer to outer. Or you put an ellipse just encircling the outermost part of the abdomen.
Next question is, what is the ideal plane of abdominal circumference measurement?
Yes, as I said, it should be the strict transverse section of the abdomen where you see the stomach and you see the portal vein making a C curve. There should be a C curve of the portal vein. The umbilical vein, which is the front portion, should not touch the anterior abdominal wall.
Okay. Next is echogenic focus in the left ventricle in heart. Does it carry any significance?
Yes. So this is a thing which we are going to discuss while doing each individual parts which we are doing, systems which we are doing in the next in the next week. So we'll take it up at that time. But just to say in a simple fashion, isolated echogenic intracardiac focus has really no significance. We tend to ignore it.
Okay. Can you suggest one USD book we can go through as a reference to reinforce these lectures?
Yes. Okay. If you go on the net, there is a book by it's by Abu Ahmad. Okay. It's called Basic Obstetric Ultrasound. That's what its work also recommend. Available as a PDF. You can go and download it on the net and you can read it. It's available for free.
In which plane do we measure the bladder?
In which plane we measure the bladder? In the longitudinal plane. You have to take a sagittal section of the fetus. measure from the bottommost part to the dome of the bladder. From the base of the bladder to the dome of the bladder.
How to comment on cervical status at first scan?
Cervical status, we have not come to evaluation of cervix as yet. There's another separate lecture for it. We'll tell you all the details on that.
Yeah, we have session on 12th Saturday.
Yeah.
Okay. Ventriculomegaly diagnosis and follow-up.
Ventriculomegaly diagnosis and follow-up. See, lateral ventricle measurement, anything about 10 millimeters is dilated ventricle. Between 11 to 15 millimeters, between 11 to 13 and 13 to 15. So this is mild ventriculomegaly, and mild ventriculomegaly has got its own algorithmic approach of the thing. We rule out infection, we rule out aneuploidy, and we look for other associated anomalies and see whether they are progressing or non-progressing. If it is severe ventriculomegaly, depending on why the ventriculomegaly is, whether it's what type of ventriculomegaly it is, the counseling will change and the diagnosis will change.
Okay. Please show once more cursor moving on the fetus.
Cursor moving on the fetus? Well, I don't understand what it means.
I think they want to see the video again, how to do the, take the planes.
Okay. You mean in the 6-step approach, or is that what they wanted?
This question is related to video only, sir.
Angulate the probe downwards and upwards.
This
to
one?
See the presenting part. And as you have shown me the presenting part, I can see the bladder. Obviously, it's a breech presentation, and the spine is to the mother's right. So, in other words, this baby, I'm seeing a cross section of the spine. That means this baby is lying longitudinally on the abdomen with the breech presentation and the spine. And I'll move to the left.
So I don't understand.
And move again, do the same activity. So deliberately, I'm just moving my probe.
Okay, we can't run through the 20 minutes all over again, no?
Yes, sir.
Yeah.
Yeah. Next question is, can the probe be taken upside down from transverse to vertical?
Transverse to vertical, upside down means what? See, the probe from transverse to sagittal should always be clockwise rotation. From sagittal to transverse, anti-clockwise rotation. That's a simple way of understanding. Keep the probe, the front end of the probe should always face the right side of the patient or the head of the patient. That only that is allowed. Opposite side not allowed.
Okay, sir. Next question is ideal plane of BPD measurement.
Transthalamic plane is what we routinely measure. Most of your charts which are available are in the transthalamic plane. If you use Fetal Medicine Foundation charts, they use it in the transventricular plane. Both are okay. According to the ISWA guidelines, either this or that, but you must use those specific charts.
What is the significance of thin CSP?
Oh, I think it's completely out of the purview of today's session. We are going to take a CNS talk is going to come, so we will discuss that.
Okay. Sir, are there any videos that we can see to learn good scanning techniques?
This is what I showed you now. See, scanning technique is hard. I'll tell you one very simple tip. Every baby is lying in a different position. So by just watching the hand movements, you're not going to learn anything at all. What you should learn is what are the basic probe movements, that what it will do to the fetus. That is, if you rotate the probe, what happens to the fetus? If you angulate the probe, what happens to the fetus? If you rock the probe, what happens? So what kind of anatomy that will come on the screen by your probe movements, that is the only thing you need to master. So the next thing you should do is, once you put your probe just above the pubic symphysis and know what is the presentation and the lie of the baby, you should actually, you can get a small doll, baby doll, and put it on the table in the same position as the baby is lying down inside. So quickly you'll get oriented to which part is where. So then you move your probe in a very systematic manner. What should I do to get the longitudinal axis of the spine? You control the spine of the baby, you control all parts of the baby. Very easy. So you need to do a good sagittal view of the spine from the cervical spine to the sacral spine. And that is what you should practice. So from the sagittal spine to, if you want to go to the transverse of the, get the abdominal circumference, you just move to the coronal view, then you do a rotate 90 degrees. From the sagittal spine, if you want to get the head, you get the cervical spine junction, rotate the probe 90 degrees and move forward. So these are things which you will learn as you work on each patient. First, understand the probe movements. The second thing you should always do is, generally what happens when people start doing scans, they put the probe on the body and whatever information comes on the screen, they try to understand that information. That should never be the case. You should control what part of anatomy comes on the body. That is when you have learned obstetric scanning correctly. That is, I tell myself, I want to see the lateral ventricles. That's what I want to do next. Then I ask myself, what should I do to get the lateral ventricles? So I move my probe deliberately to get the lateral ventricles. So I go in search of each part of the fetal anatomy and don't interpret the anatomy which comes on the screen. This will be your absolute turning point when you change your thought process from getting what you want to reading what you get.
So people want to know the name of book again, the book you just now recommended.
Okay, it's called Basic Obstetric Ultrasound by Abu Hamad.
Sir, I have shared the link to download both in
very
the
good.
chat box and the question
Sure.
answer box.
Thank you, Sean. Thank you very much.
I think we are finished with all the questions.
We're also run overtime, so I think we'll stop here. Okay,
thank you so much, sir.
Thank you all for being here. See you on Saturday.
Thank you, sir.
Thank you, everyone.
Thanks.
Thank you, sir, so much. Thank you, everyone. All the delegates are very proactive and curious to know about many things, isn't it?
Yes, yes.
Many concepts got clear, sir. Thank you so much.
Thank you. Bye.
Thank you, sir.
Bye.
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 Divya, how was the virtual demo?
Virtual demo was amazing, sir. बहुत.
Quite well, because I was a bit nervous.
Sir, everybody wanted to see it again with the simulator
Yes,
because it was rotating and as well as simultaneously it was showing the screen.
Yeah.
So people were very happy and there were 2 more questions to repeat the video.
Yes.
Well, sometime later. Anyway, it's going to be available on online for 15 days. No, they can
Yes,
go
yes,
at it
yes.
again.
Yes, sir.
It was a wonderful experience, rather.
Yeah.
Amazing, sir. Yeah. Okay, bye. Bye, ma'am. Bye, sir.
Bye. Bye, sir. Thank you, sir. Thank you so much. Let us meet on 12th.
Yeah.
Thank you, sir. Thank you, ma'am. Bye.